Well, good afternoon, everyone. I nearly said good morning, which implies I'm still feeling, really quite lively and awake and sprightly, which is a good thing, isn't it? I hope you are all too. My name's Julia Manning. I am Dean of Education here at the Royal Society of Medicine and Honorary Professor of Practice in Computer Science at UCL, but my background is clinical originally. It's a real pleasure to invite all of you here with us for this session of Medicine and Me, Living Our Best Life, examining innovations to deliver optimal care for people with genetic bleeding disorders. The Royal Society of Medicine, as I expect some of you will know, is a multidisciplinary organisation. We welcome healthcare professionals and the public from every specialty in medicine and clinical care. And this is a home for everyone with an interest, whether you are clinically qualified or not, whether you have a vested interest in a particular health topic, or whether you are just an interested other, or indeed working in the innovation space, because innovation is very much part of what we are interested in here, is part of our core mission, and it is one of our strategic pillars. So all things forward-looking and seeking to develop better ways of working, better practices, because there's never one best practice, is what we're interested in. And we have been for the past 220 years. So we date back to at least 1805, meeting not necessarily right on this site, but not far from it. I'm told doctors used to meet at a coffee shop around the corner to start talking and sharing ideas about what was happening in their particular fields of special interest. So housekeeping before I forget, and that is no fire alarm is anticipated or no, is planned. So if the fire alarm does go off, then please follow the team who will show you the way out of the building onto the safety of the street outside. Don't stand in the street, stay on the pavement. And I think, are we recording today? I'm just looking for nods. Okay, so we are recording today. Will it be available afterwards? On YouTube, fantastic. So you can reabsorb all the information and review all the information that will be presented to you here today. So the Royal Society of Medicine, we pride ourselves in offering a valuable neutral space. We're apolitical, we don't take policy positions, we don't make policy recommendations, but we do facilitate discussions and debate and sharing the latest in research. So it's wonderful to have all of you here today, and particularly those who are speaking, have taken time to share their expertise with those who are in the audience. So it's my pleasure now to hand over to Kate Burt, who I'm sure many of you will know already. She is the CEO of the Haemophilia Society. Thank you very much for being with us today and for hosting this event.
Well, thank you, Professor Manning, and thank you to everyone who's here today. 2025 marks the 75th anniversary of the Haemophilia Society, so we have got a way to go before we can match the Royal Society of Medicine's achievements, but we're very grateful for the Royal Society hosting us today as we kick off this important year. And I also want to say a huge thank you to everyone here, and particularly to Dr. Mary Mathias and Dr. Susie Shapiro, and our own Head of Policy, Deborah Morgan, who did so much to create today. So thank you to all of you. Many of you will understand bleeding disorders in the room, but many of you won't. So I hope that you hear some really valuable insights. And most importantly, we have the patient voice of people with bleeding disorders. We're called the Haemophilia Society, but we represent everyone with a bleeding disorder in the UK. So you'll be hearing from some of our amazing Board of Trustees who represent the voice of von Willebrand's disorder, factor V deficiency, Glanzmann's thrombocythemia. Some of them are parents of children with a bleeding disorder. Some of them have bleeding disorders themselves. But the common theme they have is it's a rare disease that is sometimes very little understood, including in the clinical setting. So I hope it's a really insightful and valuable afternoon. Thank you all for coming, and we look forward to some really great panels. And I'm going to hand over to our president, who took over as president of the Haemophilia Society at the end of last year, having served 6 years as our chair of the Board of Trustees, Clive Smith. Thank you very much.
Thank you, Kate, and thank you everyone for being here. I have the pleasure of chairing this afternoon's sessions. As well as being the former chair and president, I have severe haemophilia A myself and 2 brothers with severe haemophilia A. I will share some of my experiences, but I know we have an incredible number of speakers here this afternoon, many of them smiling back at me in the, towards the front. So as well as new faces, there are many old faces here too, which is great to see. I'm simply going to say this, that it's fantastic to be here, but the subject matter is incredibly important because, as you'll appreciate, for many of us in the bleeding disorders community, we spent rather a long time, particularly over the last 6 years or so, looking back. So it's a pleasure because when the inquiry, the public inquiry into the infected blood scandal came to an end, I said to many people that one of my great hopes of the future was that we could start to look forward a little more than we've been looking back. And hopefully today marks the start of that. So without further ado, I'm going to introduce our first speaker before we move on to our first panel session, who is Nicola Curry, who is a consultant haematologist at the Oxford Haemophilia and Thrombosis Centre.
Thank you very much. My name is Nikki. It's a great pleasure to be here. I don't think I've ever been to the Royal Society of Medicine. It's lovely. So my job for the next 30 to 40 minutes is to talk about new treatments for inherited bleeding disorders. And I am an adult doctor, so if there are things about children, we may have to talk to Mary about that because it's not something that I'm quite so familiar with. But just for those of you, I'm going to talk about new treatments or current and new treatments for different types of diseases. Initially, I'm going to talk about haemophilia, then von Willebrand disease, and then other. And you'll see why I do it in that order, because I've got the most to say at the start and much less to say as I go along. For those of you that are less familiar with haemophilia, haemophilia is caused by a reduction or complete lack of coagulation factors 8 or coagulation factors 9, causing haemophilia A and B. But if we look at, so when I first started as a doctor, which was quite a long time ago now because I'm getting quite old, we had very few treatments, actually, a standard treatment for patients with haemophilia. And this is, if you'll notice, this is the evolution of haemophilia treatment. It starts at around the 1950s, because prior to that was whole blood, which obviously, as the name suggests, contain everything in it, including coagulation factors. But then we moved through treatment, which needed us to be able to work out, not us, me at all, but clever scientists, work out what the factor 8 and 9 gene looked like, and then what the protein looked like, which then enabled us to manufacture recombinant factor. So we were able initially to give plasma products where we had fractionated out coagulation factors 8 for haemophilia A, coagulation factor 9 for haemophilia B, and then we got recombinant products, and those recombinant products for haemophilia started in around the early 1990s, and that's all we were able really to give. So, and you'll notice that this slide finishes at around 2015, and there wasn't a great deal of innovation, if you like, across that time. But if you now look at the last 10 to 15 years, there's been a huge amount of innovation, and I'm going to go through some of this in a little bit of detail, but really talking about it in terms of practice and how to optimize treatment for our patients together with our patients. And so at the top, we've got treatments for haemophilia A. In blue, we've got treatments for haemophilia B, and I will go through those. But now, instead of us sitting in clinic with our patients and saying, well, you could have this factor concentrate or that factor concentrate, we now have a multitude of things that we can give in different routes, in different ways, that are helpful for different reasons, which does make it much more exciting for everybody. But also, in terms of individualising care, it takes quite a lot of understanding and working together to get to the best solution for each patient. So just to go slightly back to the beginning, the principles for haemophilia treatment are essentially to replace or to manage what is missing. And what we know from this slide is, I'll just talk it through very quickly. There are 168 hours in the week, okay, from start to finish. And along the bottom here is number of hours in increasing number of a person having a factor that's basically undetectable. And the greater that time that you have no factor 8 or 9 about, the greater the likelihood is that you're going to bleed, because this is how likely are you to have no bleeding. So you're more likely to bleed as you go this way, and it's different depending on whether you're younger versus older, and part of that is because of, at this time when this was done, looks at whether somebody has joint disease or not, and also how quickly you keep hold of your factor, etc., at different ages. So we originally were looking at trying to maintain people's clotting factor levels at a relatively low level, around 1 to 3%. But then what we also started to look at, because we all develop together, was to say, okay, how about what happens if we've got somebody who's like me, who might do a bit of cycling to get to work, but I certainly don't go and play football or any more contact sport. What is the difference between those two things? Because we're all variably active or less active throughout our week. These are two graphs. It hasn't come out very well, that one over the other side, but these are two graphs looking at activity levels. So this is low activity, this is high activity. So I kind of look at that and go, well, that's a bit of going to the office. This is a bit of going and playing football. This is the levels. This was a study done about 5 years ago looking at what would the levels be where you know that you're not going to get a joint bleed if you are doing high risk activity or low risk. This is if you've got joint damage, and this is if you have no discernible joint damage. So you want to keep your factor levels a bit higher if you've got joint damage compared to if you don't, is the bottom line of this. And if you're doing more activities, you're going to want your factor level to be higher. So those are the things that we as clinicians with our patients need to start thinking about when we're thinking about the treatments that we've now got in order to individualise what we're doing for patients. So again, just to talk, so many of you will be very familiar with these, some of you won't be, but this is how I draw things out for basically for my head, but also to try to demonstrate what's happening for patients as well. So if we imagine that this again is our week, and this is our clotting factor level, so factor 8 or 9 level. And if you have severe haemophilia, you've got relatively no factor 8 or 9 if you haven't been treated. Give yourself treatment, shoots it up within a couple of minutes, and then over a certain amount of time, which is variable according to your age of your patient, according to what clotting factor it is, it will come down, and we look at that and call that about half-lives. And in the past, our standard haemophilia therapy that we had up until 15 years ago, factor 8 treatment was given often every 2 days and factor 9 every 3 days. And we were aiming to keep the factor level above what we called a trough of somewhere between 1 and 3%, maybe 5%, to reduce spontaneous bleeding. We knew that that wouldn't stop people having traumatic bleeding. We then moved on to having extended treatments. I'm not going to talk about those so much today, but what that meant was that we had some new clotting factors, particularly for factor 9. It worked much better than for factor 8 up until now. That meant that the way that the product was kept in the bloodstream meant that it hung around for significantly longer. And so you're here, you're very nicely protected against spontaneous bleeding. But if you remember when we talked about high risk activity, you've got quite a little while here with a lowish level, comparative to if you were going to go and play football, you might want to be doing it there. Here, you might just be wanting to do it once a week. So these are the things that I'm just trying to highlight that we have to start thinking about because we've now got choice. So just for haemophilia A, one of the future products that is about to be available to our patients with haemophilia A is, I can't pronounce it, it's called EFA. It was when it was in clinical trial, it was called BIV001, which I can say. EFA I can also say, but it's basically, what normally happens with factor 8 is it binds to a big protein, von Willebrand protein, and the von Willebrand protects it from breakdown. We couldn't, up until this product, get away from the fact that trying to extend factor 8's life cycle in the bloodstream, we had to try and uncouple it from the von Willebrand factor. And this drug has enabled that to happen. It's got this fancy thing called an extend polypeptide thing. It doesn't really matter. But basically what it means is that this drug hangs about for quite a long time. So the half-life, instead of for factor 8 treatment, which is somewhere around 12 plus to 18 hours, it's at 32 hours. And this is very recent data that shows that for those, there's been clinical trials that shows that if we give patients a dose of EFA here we are, days after treatment, at day 7 after treatment, this is a logarithmic scale, so it's not completely straight, that we go from about 125%, normal range 50 to 150, down to 15%, which is in the sort of very mild haemophilia range by day 7, which enables patients with haemophilia A to have a replacement coagulation factor that keeps them up very beautifully for a week, and treatment frequency and injection frequency is reduced down to once every 7 days. So that is very exciting. I don't know the dates of that. Someone else more clever than me might know when we might be able to get it. So those are replacement factors. So we have multiple of those now, and the EFA is the most exciting one that should be coming through soon. What I'm going to move on to talk about is non-factor therapy. So these are non-replacement. We're no longer now talking about giving factor 8 or factor 9. We're talking about something slightly different in the clotting process. And this, a non-factor replacement, gives you generally, once you've got to the peak level, a sustained level throughout the whole week. And it can be given commonly under the skin in a subcutaneous fashion. So again, that the difference is that's beautiful to prevent you having spontaneous bleeding, but it probably still doesn't give you some of the peaks that some people might benefit from. So what are these drugs? Many of you will have heard about this one, particularly patients. There's emicizumab. It's, patients will know by the name of Hemlibra often. It's been around now for quite a long time. Initially was given as a treatment for patients who've got inhibitors, and we'll hear more about inhibitors later on, but is now given for patients with haemophilia with or without inhibitors. But it basically, it's so cool. It's like, it's an antibody, but it's a bispecific antibody. So normally antibodies are like Y shapes, and the Y bit joins, often it's there to fight infections. So it will recognise an infection, bind to it, and lots of fabulous things cause it to be chomped up. A bispecific antibody has 2 Ys that are joined together like that, and so they can join one thing that they've chosen to the other thing that they've chosen. Emicizumab pretends to functionally be like factor 8. Factor 8 is a big clotting protein, and its principal purpose is to bring together 2 other clotting factors, factor 10 and factor 9 in its activated form. So that's what factor 8 normally does. And once you've got all those things together, they allow you to make a nice stable clot, because they produce something called thrombin, which is ultimately what we're after, to make a good clot. But emicizumab pretends to be this and brings together factor 10 and factor 9A, and the fact that it's brought them together in close proximity allows that thing to happen. So it pretends to be something. There is now, emicizumab's been around for a while. There's now another biosimilar. What we mean by that is it works in pretty much the same way. It was said to be that it might be a little bit more efficacious. Hasn't yet been demonstrated to do so, but hopefully it means that by having 2 of these drugs around, there's a bit of choice, and we will be able to offer it to lots of patients, although emicizumab is actually given to many patients now. What is so good about this medication? It is so good that for our patients with haemophilia who have inhibitors, it is given subcutaneously, and it can be given once a week, once a fortnight, or once a month. And it's basically very rarely doesn't work, to be honest, often, although occasionally for some patients they don't get on with it well. So in general, it works extremely well, and it reduces bleed risk for patients. So that's one type of treatment. Another type of treatment that isn't yet available in the UK outside of clinical trials, but is being licensed in different parts of the world, are drugs called rebalancing agents. So normally in health, all of us will have a bunch of clotting factors that make clots. They're called procoagulants, of which factor 8 and factor 9 are 2. And they also have anticoagulants, which are things like TFPI and antithrombin that I'm going to talk about. Basically, in general, they balance one another out so that we can all, if we are injured, produce a clot, but we produce a clot that is of the size that's important for the amount of injury that we've caused. It doesn't then extend further. So, for example, if you cut a bit of your finger, you want a nice stable clot at the site of injury, but you don't want it all the way up your finger. And so they balance one another out to enable you to produce just enough clot, just enough thrombin to make a nice stable clot. With haemophilia A or B, there's not very much of this going on, and because of that you don't have very much thrombin being made, and so your clot is a little bit weak and wibbly. The principles of these rebalancing agents are, as the name suggests, that you cut these down, and therefore the dampening effect that these things, less of this has, means that the amount of thrombin that's produced is not inhibited as rapidly, and so you still produce more thrombin than you would have done otherwise. And the aim, again, is to make a stable clot that way. So it's kind of like just taking everything down a notch, all of it. There are two types, and I'm again not going to go into them in too much detail. There is something to reduce one of the important anticoagulants called antithrombin. And the way that is done, again, it's relatively less important, is by something called a small RNA. So it basically stops that protein being produced. And then there's a TFPI and there's an antibody that stops that being made. And so either one of those reduces thrombin inhibition and therefore allows a clot to be made to its maximal. The purpose of this slide is to demonstrate that there have been clinical trials being run with both of these types of agents that demonstrate in patients with haemophilia that bleeds, the number of bleeds that patients with haemophilia have across a period of time that they're taking this medication is reduced significantly. You can see the percentage reductions at the top. So both of them work. With every medication, as I'm sure everyone in this room knows, there are pros and there are cons. And the pros of these two types of medications is that they can be given to all haemophilia patients, A and B, with and without inhibitors. And they can therefore be used across a whole bunch of different types of patients. They are given subcutaneously. But one of the main concerns, I think, with these, and what we have to learn together, and as we did for Emmy, we learned together about thrombosis risk, there are thrombotic risks with them, and one of the drugs was paused for a while to reevaluate doses and reevaluate how it should be given before it was restarted again in another clinical trial. So there are things that we as clinicians, at the same time as you as patients, will need to develop our understanding about how these medications are best used and in whom they are best used. Because from a personal point of view, I haven't been involved in either of these two sets of clinical trials, so I have no direct access to knowledge of how to use these yet, because I haven't had that exposure. We did for emicizumab in a clinical trial, but we haven't yet for these two medications. So just quickly, we've got these three medications now. They are all used subcutaneously. They can all be used for haemophilia A. Emmy can't be used for haemophilia B. And the only one really currently in the UK that's available is the emicizumab. But they are all available. But what is it that we, as clinicians and patients, need to think about in terms of choices of treatments? Because we've now got this quite a large breadth of choice. Patients will have different things happen to them at different parts of their life, and they will be different ages, clearly. They may be in the office, they may be running sport, they may be playing semi-professional football, as my patient yesterday in clinic, or they may be going to have surgery, and we have to adjust what we do for all of these situations and all of these settings. And so one choice that a patient may make may very well be different at different times of their life. And so we have to do that together with patients to try and offer as much information and knowledge as we can across lifetimes. So the final sort of really exciting medication, if you can call it that, that is given for patients with haemophilia A and B is gene therapy. And again, I'm not going to go into too much detail, but currently the most common form of gene therapy that is offered is via a vector, which is basically like a post van that delivers your gene of interest to the right place. Although, having said that, I'm not sure that Royal Mail necessarily always does that. But AAV viruses, so adeno-associated viruses, have either factor 8 or factor 9 genes inserted inside them. It's given as an infusion. It goes in the vein over, I think it's about an hour or so. And because it's an adeno or AAV virus, it homes into the liver because that's where it would normally go if it was infecting you as a kind of low-level virus. And we have had several gene therapy that have been run, and we are now, as I'm sure all of you are fully aware, or may not be, but we now are in the position of being able to offer Hemgenix, which is a haemophilia B gene therapy, with hopefully this year. Now, as I kind of alluded to before, we are learning about these things as patients are learning about them. We have been lucky enough in Oxford to have taken part in both haemophilia A and B gene therapy studies. And so we have some knowledge, but we have a handful of patients. We've had 4. So it's not huge numbers that we know very much about. I think the principles at the moment are that for haemophilia A, and these are just quick slide dashes of what's going on. So haemophilia A, there was a study run by Marin, where if you hear what we're looking at is the mean clotting factor, so factor 8, of patients across the first year, or that's first year, that's second, third and fourth and so on, and the numbers get less because we haven't got everybody getting out to year 6 yet. But you can see what happens to the coagulation factor after that first year. In general, 50%, most patients are between 50 and 100%, so have normalised their coagulation factor. By year 2, it's sort of still around 50, and then it sort of slowly comes down again. Now we are here, this is real time here. We don't know what's going to happen along there, so nobody can tell anybody what we don't know. On the other hand, haemophilia B patients, we've got one very long standing trial. So the first trial from St Jude's, I think, is coming up to 17 years out. This is the study of the medication that's going to be available in the UK. And you can see that this is each month after the first 6 months. So this is month 6, goes up to month 12, 18, 24, 30. Again, the numbers aren't huge, but you can see that the factor level in those patients has remained fairly stable. So there are clearly differences between responses, but again, we don't know what's happening up here. We have no idea about that. So what do we know so far? We know that there is a variability in response of patients, and we can attest to that in our patient group in our N=4 in our centre. One patient got very high levels, one patient didn't really get levels that went over 25%. Antibodies, so I have said at the start, we use currently the most common vector that we use is the AAV virus. This is a virus that is very common, and many of us have been exposed to it in our lifetime. And if you have an antibody against the AAV vector that the drug is going to come through in, it's unlikely that it's going to work so well, we think. So it's one of the exclusions, so some patients won't be able to get it. As we've shown, factor 8 levels can reduce over time. And one thing that I think became quite evident certainly for some of our patients was the amount of immunosuppression that patients required. So when you're given the virus in this vector form, it goes and homes to the liver, and so the liver responds to that. It gets a bit inflamed, and if the liver gets inflamed and responds to the infection, it can cause the amount of gene, the factor 8 or the 9 gene that goes in and starts to work, to drop quite a lot. So you have to prevent that response happening. And you do that ultimately with steroids most commonly, but sometimes other immunosuppressive agents. And patients can be on immunosuppressants for certainly the shortest period of time will be 6 weeks, but certainly possibly longer than that. And they have quite significant side effects. Currently, also, It's not available for children. And I'm not sure right now, there's been one clinical trial in early development for patients with inhibitors. We're not certain, we don't have enough information about whether gene therapy is suitable in that setting. So, and as I said, we can't provide information about what we don't know. There are still concerns potentially about the possibility of an association with cancer. In the several hundred patients that have had gene therapy, there have been 5 cancers reported, all reported to be unrelated to the gene therapy, but it's something that we all have to be recognisant of that we don't yet know. So it's always a balance of risk, and these are the things that we as clinicians and treaters with our patient group need to be talking about and making sure that everybody is aware of all of the pros and cons of all of the treatments that are offered, because I know that everyone's an individual and everyone will have a different thing that they want to do, and we have to offer that to our individuals. So these are the bits of things which I was thinking about that are important for patients to know, but I fully am recognising that patients will probably say that these aren't covering half of what they want to know and half of what's important to them. But the things that we can now talk about are what is better for you in terms of frequency of injection. Do you want it in your vein? Do you want it under the skin? How old are you? What is your clot risk? And therefore, are some of these drugs a little bit more risky for you because they hold a greater clot risk? How likely is it that you're going to have treatment-free zones or episodes? And what factor levels do they offer? Do they offer stable levels or peak levels? What is better for your lifestyle? So those are the things that we need to talk about. So the final thing for haemophilia A, and these are fancy slides, but because I nicked them from Susie, which was very kind of her. But this is possibly one treatment that will be quite exciting, and I'm really hopeful that the UK will be available to have this, run this study by the end of the year, but I don't know. All in the hands of the drug company. But there is basically the way that emicizumab works that we talked about. This drug company has joined a camelid, so I think it's llamas, but I'm not sure. It's one of those creatures like that. So a camelid antibody doesn't get broken down quite as effectively in the stomach as our normal antibodies. So if we are taking in antibodies, the problem with them, if you swallow them, that by the time they hit the acid stomach, they all get broken down and they don't work. Camelid antibodies are resistant, it seems, to that, which means that you can join, essentially, they won't like me calling it Emmy attached to it, but it's something like that. You can join that to a camelid and hopefully you can get it into the bloodstream. See, these are fancy slides. And they've called it INO8, and basically it binds onto the surface of platelets or at sites of where there's injury, and then provides that factor VIII/IX activity. So far, it has been looked at in dogs, and you take this medication every day, and your levels can get up. It's difficult because we don't actually know what that equates to or what that means in terms of equivalent factor VIII or factor VIII level. So it seems as though we can get it into the bloodstream of dogs. Hopefully that means we can also get it into the bloodstream of humans, and hopefully, and there will be a phase 1 study running by the end of the year, and I'm hopeful that it will be available in some of the centres in the UK, but we don't know. That depends. I think, though, that Trump may very well have helped us by the US no longer being quite so accessible for new medications. So that's a good thing. Anyway, that aside. So that is haemophilia. Von Willebrand disease. Now, von Willebrand disease is the commonest inherited bleeding condition, other than outside of general mild platelet defects. But as a single disorder, it is the most common bleeding disorder. And the symptoms of von Willebrand disease are quite different to those really of haemophilia, and in particular some of the most troublesome are what we call mucosal bleeding, so heavy menstrual bleeding, nosebleeds and bruising. This is quite stark, if you like. So across here on the haemophilia A, we've got all of the treatments that we've talked about. Von Willebrand disease, you'll notice that our recombinant concentrate, there is one available, and that's been made available or was developed in the 2010s, and it still is, we have it now available for patients in the UK, but we don't have all of the things that we necessarily have demonstrated that we've got for haemophilia at the moment. So I think we need to start thinking more about other conditions. So von Willebrand disease is a more complex, if you like. It has multiple forms, but there are some future ideas about how to start treating patients with von Willebrand disease. We have started giving more patients prophylaxis, but up until the last 10 years, that wasn't really quite so common in this country. So we are offering that now. But for some patients with severe von Willebrand disease, you have factor VIII levels that are really low, and you have von Willebrand levels that are really low. And so in some cases, treatments can be directed to increasing factor VIII levels in a way that you might do for haemophilia. And so for some patients, I'll come on to it in a second, emicizumab has been used. And in some cases, that BIV001, that EFA, is being suggested as a different treatment now for patients that have significant type 2N disorder, where they have low clotting factor VIII levels, or type 3 disease. So these are areas that we need to explore. There are other treatments that are being looked at that trying to increase levels of von Willebrands using antibodies. Nanobodies are little tiny antibodies, and interleukin 11 is a protein that is a cytokine that can increase von Willebrand levels a little bit, but the early clinical trials have not demonstrated a great deal of efficacy. And then there's another antibody that I'm going to come on to. This one in this clinical paper was called MAB508, and I'll come on to a different one in a second. So this was a study that was published at EHAD about a month ago, and this is the extent of our knowledge at the moment of using emicizumab, which is that medication that binds, that pretends to be factor VIII, in patients with severe von Willebrand, so type 3 von Willebrand disease. And in type 3 von Willebrand, you have a low factor VIII and you have a low von Willebrand level. And sometimes in these patients, you can also get antibodies against von Willebrands, which means that you can't actually replace von Willebrand protein, and because it just gets munched up really quickly. And so we've got 10 patients that have received this, and it's been efficacious in all patients. So it's something that we need to explore a little bit more, but this is the extent of our knowledge about that for the moment. Now, I just want to, because I'm very interested in the care of women in particular, there is a 10 Principles of Care of Women published by EHAD a couple of years ago. And one of those was to say that we needed equity of care across the board for all patients, but this was focusing on women. And one of the commonest conditions that women suffer from, particularly with von Willebrand disease, is heavy menstrual bleeding. And is something that we don't necessarily always focus on in haemophilia clinic, but we are shifting that and have shifted that quite significantly over the last 5 years or so. So there is a new medication called HMB002, which is an antibody which binds to von Willebrand factor and prevents it from being broken down. Means that it hangs around for longer. And this study is now running in the UK. We've done the observational study, and patients are within the phase 1 to 2 study are getting single doses to find the right dose of treatment, and are now moving into the phase 2, where patients will receive this treatment on a regular basis to see whether it reduces, in particular, heavy menstrual bleeding. So this is something that's really very exciting, but is something, again, in a clinical trial setting. So then we move on to other inherited bleeding conditions, and I'm nearly at the end. So that HMB-002 is a medication that has been developed by Hemab, and so this may be something that people will be becoming more familiar with. It's a pharmaceutical company which is developing novel therapeutics for patients with inherited bleeding conditions. And there is a study that has been looked at called for HMB-001, which again is an antibody which has been used for the treatment of Glanzmann's. Glanzmann's is one of the most significant bleeding disorders related to platelet defects, and this is an antibody that binds to the platelet and binds to coagulation factor 7 and increases the ability to make a stable clot. And there has been more than 50% reduction. This was published again verbally about 2 or 3 weeks ago at EHAD to say that this medication improves the number of bleeds that these patients have by greater than 50%. And considering our patient group with Glanzmann's don't have any prophylactic treatment, this is fantastic. But what about all the other patients with inherited rare bleeding conditions? We don't really have any novel treatments yet for those. And that's where we need to go as well, because we've got many, many other conditions that we need to focus on. So with that, I think I will finish and say that we are at a very exciting time, particularly for haemophilia. We're beginning to see that for von Willebrand's, and now we need to also see it for all of the other conditions too. Okay, thank you very much for your attention.
Thank you, Nicola, particularly as you didn't use up all your time. So we are ahead of schedule, which means our panellists can do more talking. Just a couple of observations before I invite our panellists up. First, in relation to effort, I know Ed's in the room as well. We were the patient experts on that with NICE, and I think we're hoping to get it into people's arms or backs of your hands, if you may, in the next few months. It is, as Nicola says, a very exciting treatment. In my closing remarks to the NICE committee, I reminded them of Neil Armstrong's words when he landed on the moon, that he talked about small steps and giant leaps, and in my opinion, EFA is a giant leap forward in the treatment of severe haemophilia A. The other thing, Nicola, I was really pleased that when you look at what's important to patients, you did not have annual bleed rate on there. Every time I see that on a slide, I want to shout. There is such a good thing as a good bleed, but we don't distinguish when we record bleed rates between good bleeds and bad bleeds. So if I fell off my bike cycling to work, I'd be quite happy because I was riding my bike. I wouldn't be very happy if I was sat on the sofa playing computer games, eating pizza and getting fat. But certainly from a patient perspective at times, I think we feel that the medics are wedded to annual bleed rates as being the single barometer by which we judge how well we are treating our patients. So it was lovely not to see that, Nicola. Can I encourage you to repeat that slide in the future? Good, so there we are, just a few comments and observations. Can I invite our panellists to come and take your seats, please? I will, forgive me, I can't read everyone's CVs or we'll be here till we finish. But I'll just briefly read out names and titles as people come up. So we've got Will Horsley, who's Lead Commissioner for Specialised Blood Disorders at NHS England. We've got Nicola Curry joining us again. Dr. Mary Mathias, Consultant Haematologist from Great Ormond Street Hospital, my former hospital when I was a little bit smaller. I had to move because I became so tall and my feet were hanging over the edge. They used to sing that song about Peter Crouch, didn't they? His biggies read, his feet hang out the bed. That was me at Great Ormond Street, so I had to move with my brothers, we were too tall. So there we are. We've also got Ed, who mentioned is patient representative, Dr. Joe Schwanter, good friend of mine, and also trustee of the Haemophilia Society. And we also have Helen as well as patient representative, Helen Tate's patient representative and recently elected trustee of the Haemophilia Society. So congratulations to you. Does anybody want to kick off? I can ask questions, but I appreciate we've just had quite a lot presented to us, the science, and now we're talking about the practice and the reality. I've just given you a few comments and observations as to what struck me and all of that. Does anybody want to put their hand up or kick off in terms of reflections and comments about what we've just heard?
Hi, so my name is Will Horsley. I'm actually a pharmacist by training, but I've been the lead commissioner for specialised blood disorders at NHS England for quite a while, nearly 10 years, since 2016, when the enhanced half-life factors came out. Basic error. Hopefully you heard that anyway. If you didn't, I'm not repeating it.
So, just, Clive, on your comment about the annualised bleeding rate, whilst it's not a perfect outcome measure, it is one that's widely used, and it does enable us to compare existing treatments against new treatments and new treatments against new treatments. And it's very objective, and I suppose for the non-experts and the non-patients, ultimately the people who are going to be paying for these drugs, picking up the tabs for them, it's something that's quite tangible and meaningful to us. So I think it's it's widely used, it has that currency, it is, so I think it is still useful. I think the important thing is to make sure that there are other outcomes which are seen as being equally as important, and perhaps over time they will overtake the annualised bleeding rate as well, because I know there are some other issues with that measure.
Yeah, no, absolutely, I agree. It has its place, but the point was what was important to patients, and it may be important to clinicians, it may be important to those who are paying too, and absolutely I agree. It's a useful barometer to compare all these things, but very often I've never spoken to a patient who said, I'm really glad my annual bleed rate has come down recently. But no, you're absolutely right. It's an important metric, and it's valuable in terms of a comparison and tool. So forgive me, I wasn't meaning to throw it out completely. So. Anyone else with any reflections?
Hi, so I'm Helen with severe factor V deficiency, and really my takeaway from this is people in my position would like treatment. Currently, if I have a bleed, it is still FFP is the treatment. Prophylaxis is kind of the dream, but I know that it's very rare for it to be severe, but I would say like it's massively affected my life, like menstrual bleeding, ovulation bleeding. Like this is like a monthly occurrence, and I think you feel very forgotten. I think especially when like my GP practice isn't in the same trust as my haemophilia centre, so actually getting even a referral to the right place, to the right trust, is difficult if I have a problem that isn't necessarily bleeding related but will require treatment from a haemophilia centre. And even sometimes when you go to your haemophilia treatment centre, there's very much a lack of understanding there. I think it depends entirely on who you see on the day. I think there needs to be a lot more education on the rare bleeding disorders, even for medical professionals and even in the haemophilia treatment centre. That's how I see like my hopes for the future and for better care.
I was just going to follow up with your comments about the rare bleeding disorder and education. I mean, I've got severe haemophilia A, which is a rare bleeding disorder, but arguably not quite as rare. And even in this modern day, I think even amongst healthcare professionals, when you're in the hospital, that education is sometimes lacking. I was an inpatient recently and was having an interesting conversation with the nurse that was insistent on giving me my Clexane injection to stop me getting blood clots in my legs, having just given me my factor VIII into a cannula in my arm to help me clot my blood. And the fact that I even had to have that conversation, and I'm capable, and I'm quite prepared to, you know, stand up and fight my corner, as it were, or be my own advocate. But I thought there's something here that's not it's not a difficult concept to grasp, but what you're saying, even rarer conditions, there is a big dearth of knowledge sometimes, I think. Yeah, you're right.
Ed, and I'm sure many others here, you've probably been asked, perhaps especially in an emergency situation, about how long have you had your bleeding disorder for? Which is always an interesting question. And certainly I think there's a feeling at times, so to your point, Helen, that we as patients aren't always treated as the experts we are, and that often doctors talk at you rather than talk to you or talk with you, and ask you, for example, is this normal or is this different to what's been going on recently, and try and take a history and actually find out what might have changed and ask you what you would like to happen or what you think should happen in those circumstances. Is that something that you'd like to see as part of that training and education?
Yes, definitely. I would say now, I mean, I was diagnosed at birth, but especially now if I go to the hospital, I pretty much decide what happens, because I'll be honest, they don't know. And even I've been at the hospital before with a significant knee bleed, and they just wouldn't believe that that was possible, that that could happen to me, and it did, and it's caused permanent damage. But that it wasn't necessary that damage was caused. But yeah, so I think it's kind of hard looking back, because I think when you're diagnosed from birth and then you get transferred into the adults, nobody kind of sits you down and says like what treatment is available for you, because they told my parents this at birth and no one's ever really discussed it with me. So I feel like especially patients and medical professionals need more training to kind of like, I don't know, like work together and understand like together, because I think there is only kind of not very many of me in the country, so really they need to listen to me and other patients with the same kind of experiences and share knowledge between trusts and between healthcare professionals. Does that make sense?
Joe, perhaps I could ask you, we've just seen one of the slides towards the end there about the timeline of treatments and advances, certainly in haemophilia and now for von Willebrand's disease. What are your reflections in terms of where we are now in terms of the treatment of VWD?
So I think there's a lot of exciting opportunities in terms of treatments that are on the horizon. I think we're still, a lot of those treatments and trials are very sort of London, southern centric. So for those who haven't noticed, I'm from the north of England, and certainly there's very little opportunity in our centres. In fact, a lot of the people that I'm speaking to are completely oblivious to the opportunities that are available to them for von Willebrand's disease in terms of emerging treatments. And I think that is problematic in that we supposedly are the most common bleeding disorder, but if you go into an emergency room and tell them that you've got VWD, certainly in the north of England, you're usually met with a blank face, and usually it's us who are the experts and it's us who have to educate the clinicians and tell them actually what the treatment should be, which as a patient doesn't really make you feel very safe. I think if there was a way that we could treat ourselves and those opportunities became more available to us in terms of simple treatments such as subcutaneous injections, I think that we would all feel a lot safer and a lot more confident in terms of accessing treatment, particularly in an emergency situation.
Yeah, thank you. Mary, I'm going to turn to you.
I'm choosing my words carefully, but I think it's okay for me to say that the treatment that Nikki was talking about for von Willebrand's disease is in the process of being about to be launched in a clinical trial in the UK. And one of the centres is in the north of England. I think, you know, it's been a really slow start, hasn't it? But I think that is something that we are all desperately keen to move on with, for sure. From Helen's comment, I think we have quite a lot of children with rare bleeding disorders in London, which is partly because of our ethnic mix. And therefore, I guess I have an expertise in that perhaps my colleague in, I'm just trying to think of somewhere, Exeter, possibly, may not, because of their ethnic mix. And I think one of the things which I hope may be encouraging or a reassurance is that certainly within paediatric bleeding disorders care, we now have a national MDT. So if one of my colleagues in a part of the world who's never seen a patient with severe factor V deficiency diagnoses one, they have access to our national expertise on that. And I think we're all, as Children's Trees, pretty good at reaching out about that. And I won't, but I give you an example later of something that was really helpful in that work for us, because it combined all of our knowledge and it giantly changed the way I managed the patient. So, but you're not wrong. You walk into an A&E anywhere in the world and go, I've got severe factor V deficiency. If you're lucky, they'll be Googling it. And if you're not lucky, they won't be. And part of it, isn't it, is giving you and people like you the tools and the confidence to say, this is what I've got. These are the people you need to call. Step away with the Clexane.
Yeah. Mary, could I ask, certainly when I was a patient at Great Ormond Street, you know, when prophylaxis came online, you know, I had two brothers with severe A as well, and I've said this in a couple of talks over the last year or so, and treatment decisions for my parents were relatively straightforward in the sense they had to answer two questions. How much do you want, and when do you want it? So do you want to treat on a Monday, Wednesday and Friday, or do you want to treat a bit more, or do you want to do it every other day? And those were really the questions they had to answer when treating even 3 boys. Now, I dare say the decision to treat just one boy with severe haemophilia is far more complex. And I can say that now my 2 brothers and I, we're all on different treatment regimes, all under the same doctor, interestingly, but all on different treatment regimes. So whilst we look at all of this and we smile and we're excited and we're happy, particularly for people with severe haemophilia A, because there is so much treatment choice, but from your perspective as a treating clinician, what challenges has that presented you?
Thank you. Excellent question. And I think, one of the challenges it presents is just, it's more time, isn't it? Like, so a conversation of your child has severe haemophilia A, we can prevent bleeding, they can have a normal life, they can do pretty much anything apart from boxing and contact rugby, but you're going to need to learn in some way to give them a factor VIII injection every 2 to 3 days. That was, fairly straightforward. Yeah. And now we've got the fantastic choice of starting the babies and small children on emicizumab for severe haemophilia A, and that is a fantastic choice. It means we don't have to put a portacath in all our babies, but it isn't perfect yet wherever Steve is, and they may be making it perfect over the next 5 to 10 years, but it doesn't prevent all bleeding. And of course, small babies, if they do need extra treatment, that's quite complex. So again, as Nikki said, you've got to look at, one of the things with families, I've had a parent who said, no, we're going to have factor VIII because I do a lot of sport and my children are almost certainly going to do a lot of sport. This is what I think we want. Yeah. So at the beginning, I'm going to say actually at the moment, if I think over the last 5 years really, the majority of our families are choosing Haemophilia up front if they haven't got experience of giving factor VIII to an older child. So the ones where multi-generations of factor VIII, often they're going for factor VIII. But the ones where it's a new diagnosis, they're choosing, understandably, a subcutaneous treatment that doesn't involve portacath. But it's not a one-time decision, as Nikki said. What's right for you as a 2-week-old baby is not necessarily right for you playing super competitive sport at 12. So I think it's that idea. One of the conversations we're having is saying, this is now, we're going to regroup in 4 years. Then we might regroup in another 10 years. And it's the idea of evolving treatment across your lifetime to suit you the most.
What's really interesting, because I'm an adult treater, and I had my first transition patient who was 17 about a month ago, who was unable to self-inject with severe haemophilia because he'd been taking Hemlibra for the last 5 or 6 years, at which point he just started it at the age where he was about to start self-administering, and his dad was only able to do it. He hadn't bled for 2 years, and his dad hadn't injected him for 2 years. He was a little bit freaked out, and it was quite interesting because the flexibility that you talk about. So we had equally a type 3 von Willebrand patient who I saw having started on prophylaxis, and she just had the freedom of going somewhere. And this lad, we talked to him about, well, we probably need to teach you how to self-cannulate. And so it's there's pros and cons of all of these things, and the flexibility needs to be maintained, but that's not without cost.
I think I was 9 when I learnt to inject, but it didn't stop my mum coming on a school trip to France when I was 12 with my twin brother and I. I don't think she'll be rushing back to Dieppe, but I think she probably thought it was going to be Paris or Nice or somewhere. But when she found out it was Dieppe, she was vaguely disappointed. But there we are. But it's a catalyst, I tell you that, to get you treatment, to start injecting, knowing that your mum won't have to come on a school trip with you.
That remains the same.
Quite. Yes, I'm sure it does. So
it's not the same, is it?
It's not. It's very different. So. Yes, I think we've got some questions. Susie.
Hi, thanks. So I guess 2 questions. So the first one, I guess, is to acknowledge Helen, Ed, Joe, totally hear that for the most rare, even within the Haemophilia Centre, but certainly outside the Haemophilia Centre, no one understands bleeding disorders. That is despite us teaching them as medical students and going to ED, like to A&E and all sorts. So it's not that we're not teaching them as medical students, It's that within their massive syllabus, this is a really small part of it. And so what I stress when I give them a talk about bleeding disorders is actually the most important thing is to realise what they don't know and to call the Haemophilia Centre. But then it's with us to keep on saying to you guys, actually you need to be your own best advocate, and giving you the confidence to do that. So I don't know if there's a better thing, because it's not easy to be your own advocate, even with the phone numbers that I know sometimes you give them our phone number and they don't call us. So I suppose one question is, knowing that we are doing that education, does anyone have any ideas of what else we might be able to do? Because I think it is really challenging. So that's one. Shall I hold my second one?
Yeah, shall I give a brief answer? Just something that's occurred to me. It feels like there needs to be a central repository of information, so that when one of us goes into A&E, we say, right, here's a page on the internet. So instead of Dr. Google, we can say, here is a website from the UK HCDO or someone like that, a trusted source of information. Because I think as patients, we're looked at very sceptically. When I went into A&E once, I was telling them all about my medical history. And because I'm fortunate to be educated and remember my medical history, the doctor was looking at me like I was a hypochondriac, because I could remember in vivid detail what had happened to me 20 years ago, that I had supraventricular tachycardias and I passed out and I missed one of my A-level exams, which I was very happy about. But she was looking at me particularly cynically, and actually I thought, you're taking me the wrong way. I'm an asset in this conversation. You're looking at me skeptically as if I'm a challenge. And I wasn't. So I feel like there should be a central repository where you can say, look, here where to go. This is what factor 5 deficiency is. This is who you need to speak to. This is what not to do. This is what not to treat them with right here, right now. Because we're all talking about times when we've had to advocate for ourselves in A&E. That's when we're conscious. What if we go in and we're unconscious and we're not able to advocate for ourselves? That's the fear that we all live with. And I've just realised I'm not wearing my medical alert, which I'm really annoyed about. But it's a genuine concern. So that's my short answer. Anyone else?
I think what you said about or people were touching on it about people not being taken seriously or not having the ability to advocate. I don't think that's exclusive to bleeding disorder patients in healthcare. Immediately off the top of my head, a friend of mine is diabetic, and I know they've had a couple of inpatient admissions where it's kind of been their control of their diabetes that they've been controlling for years has been taken away from them by the ward team, and actually they're the person. So I don't think it's exclusively haemophilia. I think it's a general need in healthcare for actually accepting that patients do know how to look after themselves and their conditions for the most part. Admittedly, some people may not, and certain circumstances maybe not, but as a general rule, regardless of the condition, you're living with it day in, day out. You know perfectly well how to manage it. And if you know that you need to do this, that's likely what you need to do. I've had experiences where I've gone to A&E, severe haemophilia, but I don't really let it hold me back, and it will probably do me in properly one day, but I've been all right so far. But I have a very active life, and that does mean I end up in A&E more than my consultant is happy with, not so much as I've got older, admittedly. And I have had situations, you said about people not phoning. I've said, you need to phone and speak to my haematologist. This is the thing, it's 9 o'clock on a Friday. No, on-call haematologist, please do it. And they're like, we're just going to see if we can get hold of our haematologist first. I'm like, don't waste your time, because they will just tell you to phone this specialist. Or this is the injection. So I had a stomach bleed once, and I did an injection before I went to the hospital, and I was asked why I'd done that. And I was like, because I don't want to die, because you delay doing it. That's the reality of and that's in the last 4 or 5 years. So we're not talking 15 years ago history sort of thing. But I think it's a general theme in healthcare. Patients, it's touted as the patient expert, but I don't think it's truly believed by everybody that you come across as a healthcare professional. And I am slightly biased in that I am also a healthcare professional in my current role. So I see an awful lot of interactions of doctors and nurses with patients, and I see this repeated day in, day out, and I'm often advocating for people that shouldn't really need me to advocate for them because I've been overridden by this authoritarian hierarchy sometimes. And I'm aware here that I'm tarring with a pretty heavy brush, and there's an awful lot of people that are not like this, but this is what I see professionally, and this is what I've experienced personally, and I'm sure I'm not the only person. So I think it's a change in the education methods, perhaps, rather than just pushing the message out there.
I'm going to take some questions from the audience. I'm conscious I've been looking to the right, so I've missed questions because lots of people over to my left. I think there's a lady in the middle with the microphone there. I agree. So the point there was that there's an aspect of education and communication, and to actually just defend A&E doctors for a moment, I think there are something like 6,000 or 7,000 rare diseases. I bet none of us in this room could even name them, let alone what they are and what the symptoms are and what the diagnosis and the treatment and everything else is. So there is that piece when we walk in. So as much as we educate, you might never meet someone with factor V deficiency in your practicing career. So why should you know about it? I think that's a fair response that some might come back at us with. So I think your point, not just about education, but about that communication piece, that if I don't know something, where do I go? Not just Dr. Google. Where is a trusted place that I can go to find out about these things? Come across.
My point was linked, I don't think this is working quite right, was actually linked to A&E. So I'm a boy, teenager who's got haemophilia B, so I'm direct. So I've had many a visit to A&E, unfortunately, connected to the hospital, and ironically, when we're entering A&E, the records that they go through are different from the Haemophilia Centre, even though it's the same hospital. So every single time we've gone through A&E, when my son's had a joint bleed or anything like that, they start trying to access putting lines in his wrists and feet, and my son, who was younger, going, no, my right arm, it's here, and he's been advocating his own care. In the end, there was that many issues. The unit at the hospital then changed the system, and they implemented care plans for all the haemophilia children at the hospital into A&E. To help, because it'd be things like the size of the needles, the sprays, everything, to the point where instead of my son having cream, it was, you've got to use spray. So it's like this. So because otherwise the registrars, the consultants were even overriding what we were advocating for. So that alleviated a lot of stress, because we're talking obviously a lot about the medicine, but what was happening was with my son trying to develop his confidence with needles and treatment, was because he was on demand. What would happen is by the time he'd have treatment and he'd go through all that drama, the damage emotionally then that would happen, we would go backwards. So then we would have he would then struggle then when he'd go for his normal treatment in the Haemophilia Centre, and we'd have needle phobia, etc. And we're still dealing with that now, and he's nearly 15. So I completely support what you're saying. And just for some simple communication to alleviate the stress of patients.
And that obviously has the potential to impact on his treatment choices in the future, yes. Route of administration. Good. We've got two more questions from us. There's just the lady at the back there, and then I'm going to come to this lady here in the yellow jumper, the lady to the left.
Thank you. I'm actually a professor of clinical genetics, so I only ever deal with rare disorders.
Lucky you.
So there are more than 2,000 that I deal with on a regular basis, if you can call anything that's rare regular. And so I think giving individuals either an app or a letter that they can take with that states, I am the expert in this, and I tell parents right from day one, you're going to know more than me in 5 or 10 years, and I don't care that you know more than me. Actually, I want you to, because you're going to be the person who's going to be dealing with this on an ongoing basis. So I think we have to get away from the, they don't know when we go in. I teach clinical genetics to med students, and I tell them, this is how you're going to have to be. Humble and ask your patients most.
Yeah, thank you. I think it's the point, isn't it? We feel we lack credibility, and I feel like when we're there, we need something that the other person in the room is going to accept as being credible, and actually for it to have him. I'm just going to take one more question from the audience, if that's okay, and then I'll come to the panel. So the lady in there has been waiting patiently.
Hi, I'm a consultant in pediatric intensive care, and in defense of doctors, it's not that we haven't been educated or we don't know what to do. There have been so many advances in medicine that you just cannot keep up with everything. Yeah. And you just need to, in the case of pediatricians, we always ask the patient or the parents, and you just need to know when to phone a friend, and in my case, it's Mary Matthias.
Very good. A good friend to have. Thank you very much. Will, you were going to...
Thanks, Clive, and everyone else for your comments. So, as a commissioner, I haven't previously been aware of this. Would appear to be quite a common problem that patients are facing, and therefore haven't spent any great time thinking about it. But the first thing that came to mind, and hanging on the back of the idea somewhat floated by our geneticist friend in the corner, the only option that I think would be acceptable, credible, and accessible in an A&E or urgent situation would be the NHS app. And I think, if you showed that to an A&E doctor, they're probably going to believe that because it's on the NHS app, and it couldn't get there if it's not legit. And with it being on an app, mobile phone type of setup, it's going to be accessible in most situations, I would think. Yeah. So that's my first thought, is that if you can collectively, as a clinical group, the UKHCDO and the Haemophilia Society, produce templates which could go on there, that's the sort of thing that you could potentially, or someone who's got your care and responsibility could hand them and say, there's the plan, or there's the kind of headline info you need. Don't worry about trying to educate people at this point. They just need to know what to do and what not to do.
Because the lady at the back mentioned about having a treatment plan at A&E, but that's probably specific to that hospital. If he wasn't going to that hospital and it was on a school trip, for example, something was happened, then the whole process falls apart again, doesn't it? Mary just had her hand up just before you, Joe.
It was just to offer a possible ray of sunshine in this respect. And we're working with a company at Great Ormond Street, which I have conveniently and quite genuinely forgotten the name of. I'll remember it tomorrow afternoon at about 3:30. But this is a company set up by a couple of siblings for this very reason that you're talking about. They had or have a disabled sibling, and had numerous A&E attendances where they had numerous suboptimal interactions with healthcare professionals. And they have set up as you were alluding to your thing that you haven't put on, Clive, thank you. It's that, but it's that plus. Yep. So what you would get is you register as a patient, so it's not the clinician doing it for you. You go on the website, you register, and you are in charge of how much information you put on there. And you get individual QR codes associated with you. And so for my patients, what's terribly exciting is you can stick them on their bike helmet, on their bike frame, on their lunchbox, on anything else, and the child is on the floor bleeding, and somebody just needs to take a picture of the QR code, and it leaps them through, and there's a sort of call this number, which is a parent. And for some families, that will be all they see, and some may say, okay, I'm happy for the person looking to see that my child's got severe haemophilia. But you're in control of how much is outward facing. And we're sort of interacting with them at the moment, but I think it's a really exciting step forward. And it's not, for me particularly, it's great because in stickers, you know, QR codes on stickers, how good is that? You know, so, but it will apply also to adults. And I think, notwithstanding what you're saying about the NHS app, it would be another way of showing to somebody in A&E, this is my care plan. Yeah. And we as a centre can push out common information. This is what I need you to do in this situation. So I think there are IT solutions.
Sure. We've got 5 or 4 minutes left. I'm conscious we may have strayed slightly off topic of new treatment options rule, but I think to relate it to A&E, I think it makes the A&E situation even more challenging because of the variety of treatment options. And as you say, sometimes the safest option is to treat before you go if you're able to do that. So just for the last few minutes, just want to try and bring it back to new treatment options for all. Is there anything from the audience that anyone want to say about new treatment options, or anything from the panel that we've not covered? Will, I think you had your hand.
I mean, I very briefly give the Commissioner perspective, and we only really would become involved when we're dealing with licensed treatments, potentially in an off-licensed use, but generally speaking, licensed treatments in a licensed, for being used in a licensed manner. And we will look at whether they work and whether they're safe, etc. It usually boils down to cost, let's be honest with you. And so once we agree to commission something to make it available to fund it, that's that's a large part of it done. We will maybe ensure it's used only at the places where we think it should be used due to certain infrastructure or expertise being available at that point. But even within the treatments that we have already agreed to fund, we do see quite big differences in how popular those treatments are at individual centres. Indeed, if you're really interested, you can look that up in the UK HCDO annual report. But we don't really, when we're paying for treatments, we're not really buying the treatment, we're buying the outcome. And actually, if 2 different treatments are going to do the same thing, same benefit, same outcomes for patients, all else being equal, we're not going to be terribly fussed about which one's getting used, because it's the outcomes that we're buying, which may be a reduction in annualised bleeding rate. Hopefully you get a bit more on that as well.
Thank you, that's helpful to know. Thank you. Anything else from anybody else? Or shall we? Yes, lady there.
What about social prescribing? What about social prescribing? Any comments about the mental health of the sufferers?
Who's that question directed to, sorry?
Any comment about social prescribing as an innovation or treatment? Is any study that can be applied, social prescribing for people with hemophilia? What about the mental health?
The mental health.
Any support?
Yeah, I don't know.
In what way? You mean mental health support for people with haemophilia?
Okay.
I mean, until a couple of years ago, what mental health support for people with haemophilia? I was only offered psychological input, and that only came about off the back of the infected blood inquiry, if I'm completely honest with you. But that's input from a medical professional, i.e. a psychologist. I have had an awful lot of supported input from my haemophilia consultant and the haemophilia nurse particularly, especially when trying to make decisions on switching to a different treatment, or if I'm not getting on with the particular. I've been on loads of different treatments over the years. The most recent one I've been on for the longest period of time actually is the EMA, what's it called? The EFA, yeah.
FNS-octocog alpha.
BIV 001. So I've been on that one for about 5 years, but there was an awful lot of conversation conversations to and fro beforehand about whether to go for my previous product onto Haemophilia. I didn't want to go onto that, 6 years ago, so I was off of that because I didn't feel confident in it on things I've read. But I had an awful lot of non-medical support from my haemophilia team, which is comprised of about 5 different specialities. You know, there's the nurse, doctor, physio, periodically a dietitian, not sure why, for me, but anyway. So even before there was the formalised kind of psychological input, I think there was still an awful lot of, in the centre that I'm at specifically, which is a comprehensive care centre, there was a lot of thought to my well-being with the treatments. And, you know, I don't know what other people's thoughts are, but...
So it's good to hear that, Ed.
Might be different in other places, though, of course.
As commissioners, we have been aware for a while through the UKHCD peer reviews that psychology support to comprehensive care centres is quite variable. Some have it to a good degree and others have none. So the latest iteration of the Haemophilia service spec, which has still not been officially signed off, but hopefully go to public consultation later this year, takes psychology as a specific component of the spec and says that's a must provide for comprehensive care centres. So hopefully we'll be opening up and expanding that. And there has been some IBI-specific psychology support funded recently at most adult comprehensive care centres in England, certainly. 16 out of the 17, I think, will have been funded to have some psychology support. And our expectation is that the majority of that, if not all of it, will convert to, in the longer term, to be available to the Haemophilia Centre as its psychology support, not just for IBI.
Good. I'm conscious of time. We are just a couple of minutes over, but that's we've talked about treatment options, and we now talked about broader treatment of bleeding disorders. So that segues us quite nicely into our next speaker. So I'll just ask the panelists if they want to go and take a seat, and then I'll introduce our next speaker. Thank you very much, everybody. So our next speaker is Dr. Charles Percy, who's a consultant haematologist at the Queen Elizabeth Hospital in Birmingham, and Charles is going to be talking to us this afternoon about what should the future structure of care delivery look like. Thank you.
Well, thank you very much. I mean, this is a topic where ultimately, whatever we say now, we've all got our own opinion, and we can all say what's going to be said is utter rubbish, and we could all be quite right. So it's a challenging area to discuss. So one of the things that came to my mind when I was trying to put this slide together is what perhaps are going to be the things that shape care. So I think first of all we'll put up some disclosures. I forgot to do that, and this is an interesting proposed slide design from Microsoft, and I've got to confess I'm much less adept than Nikki is at doing these sorts of things. You'll come onto my unoriginal artwork later on, and so this was a suggestion for empty chairs from Microsoft, so I don't know whether the disclosures mean everyone will then leave. So what are the themes and what are the shapes? And I think it's easy to perhaps think about what might influence the shape of care and the structure of care as the years go by. Obviously, we've talked quite a lot about the new treatment options. They have opportunities, but they also come perhaps with their challenges that we may or may not have thought about yet. Perhaps, famous last words in the National Health Service, we might have new technology coming along for consultations and obtaining advice. And we've obviously had the telephone for quite a long time, and yet, as we were just discussing with the panel discussion earlier, the telephone remains an inadequately used piece of equipment in healthcare. So whether this new technology will help remains to be seen. We've then got networks of care, which comes around to commissioning and perhaps the service specification, and what that might do to try and reduce some variation. And then we need to think about perhaps beyond bleeding disorders, or beyond bleeding, I would say, and prevention of wider health problems. And that leads into perhaps the NHS long-term plan, which are unusual 3 words to see together, but there we are. And so when we think of these themes, I thought to myself, well, how are they going to shape things? Because we don't really know. And I'm reminded a little bit of a documentary about the failures of the British car industry. And there were cars coming down the production line with their bonnets up, and what the manufacturer hoped was an engine in the front of it. At the very end of the production line, there was a man hammering each engine inadequately or indirectly with a huge hammer. And you think, well, we knew what the shaping things were and the themes that would come out there, but we didn't really know what the outcome would be. And so perhaps at the end of this, we might be none the wiser. So with the treatment options, what have we got and how might that influence things? Well, I think first of all, as we've discussed, the easier methods of administration obviously offer some advantages if that's going to be under the skin, less frequent, and perhaps even oral. And then we've got gene therapy, which of course, if successful, might mean that you're independent of many of these treatments for a long period of time unless you need surgery or similar. And so some of these things that are so much more easier to administer mean that you as the individual taking them will need less training and less perhaps physical skill if you're thinking about venous access to deliver that, and might on that side increase your independence. But actually, a lot of these treatments that are under the skin, for example, they're not taking away the need for factor in the setting of an emergency or an operation, but they're just preventing that chance of spontaneous day-to-day bleeding. And so actually, although on the one hand they're giving extra independence, they're taking away your independence if you then are no longer able to access a vein to give yourself intravenous treatment in an emergency, particularly if you're being looked after by people who don't know how to use the telephone. And so the other issue with these treatments, as Nikki alluded to, is that we don't necessarily have a feel for how these will work in terms of monitoring both in the short term and the longer term. And we know with some of them there'll certainly be more frequent visits for perhaps blood tests to monitor things, which then of course have got an implication about how far you're going to travel for that. So this comes on to my inability to do any diagrams myself, so I've stolen some. And I was just thinking about in terms of that treatment frequency. On the left we've got a diagram thinking about an extended half-life product, and of course for haemophilia B we've been in the position for quite a long time now of being able to give once weekly or less frequent treatment for prophylaxis. But then, as Nikki said earlier, and I'm going to use a potential brand name of Altivoct for this is F-anesticog alpha /BIV001, we've then got the potential to just be giving one injection once a week, once every fortnight, and imagine if you're having an operation, what this could mean if you've got haemophilia A. You might just be able to have one injection at the start. If you've got mild haemophilia A, maybe that would be all you would need. And then if you've got severe or moderate haemophilia A, then a second injection at the end of the week. So suddenly you've gone from being stuck in the hospital, potentially having to have people monitoring levels, administering the factor to you or administering it yourself, depending on the capabilities of the staff, to actually perhaps doing this closer to home, or perhaps being discharged from hospital at a time frame a conventional person without a bleeding disorder might have been discharged at. So it suddenly changes things quite a bit. But in terms of the short term, I think we just have to acknowledge that it probably does mean we're going to have, with a new treatment coming along, a lot more follow-up. So this is imagined, but not necessarily identical to gene therapy. You might be coming every week for blood tests initially for the first 3 months or even longer, because, as we said earlier, we don't necessarily know what the overall experience in real life will be with these. And certainly if you've ended up on immunosuppression, you're going to be coming a lot more frequently for a longer period of time. But if you'd remained on perhaps your conventional treatment, you might have just had infrequent follow-up. And if we go to the longer term, you might have even a longer gap there. So you might just be coming once a year or so. Let's say you're on an oral agent, as Nikki described earlier, you might not have any inhibitors to that, and therefore if you've not had factor exposure, why would you need to come along to the hospital for an inhibitor screen, for example? So actually, you're going to potentially have that advantage, having had a lot of investment at the start with your time and effort, to then actually being able to come less frequently. But then that, of course, means we need to be mindful of how we're going to identify any unforeseen problems. But what should all this mean in theory in the longer term? Well, fewer bleeds, and therefore, if we're then preventing joint damage, less chronic pain, less need for orthopaedic intervention, and hopefully fewer days lost from education and work. In terms of the regular review, actually, if all we're saying we need to look at some blood tests, well, could you go to your GP surgery, perhaps, or some community hub and have your blood test closer to home than traipsing all the way to the comprehensive care centre, for example, or local treatment centre? And that, of course, is quite a significant problem, isn't it? I mean, getting to the Haemophilia Centre, you've got the issues of, is there a bus network? Is there a train? Can you actually park at the hospital? All these different things that constrain that and allow a lot of wasted time if you think about it from your other activities you'd want to be getting on with in life. And as I sort of alluded to with Eftenescog Alpha or Altavoct, then potentially we might be looking at shorter hospital admissions, because if you've had your planned surgery and you can go home on day 2, like everybody else will, then you're not going to be stuck in hospital for quite so long. And in theory, although I think coming around to the issues about education of wider healthcare professionals we've talked about earlier, this should mean more deliverable care closer to home without the need to travel like you have had. So on the note of new treatments, I think we just need to think about other things that are going to influence how this is all going to work. And so, as some of you will know, and Will probably stand up and say, this is not necessarily to the letter, but the old way of doing things for bleeding disorders care was that the NHS would agree a clinical policy to cover the use, in line with the licence usually, and then the price would be agreed with the manufacturer, and then funding would be obtained, in the case of England, from NHS England's budget, and then the treatment would become available to prescribe. But now we've moved to a more conventional approach, which of course has been around for much longer for other areas of healthcare, and there the manufacturer then needs to submit application for licensing now from the MHRA, and also then to NICE, and then NICE needs to assess the clinical benefit and the cost effectiveness, and then if it's deemed to be effective and the license has been issued, then the NHS has got to provide that treatment within 90 days. So there's a slight difference there, and you're saying they're not actually having to find funding there, provided the cost effectiveness has been determined. And this comes around to the outcome measures, as Clive was talking about earlier, because the ABR is not a great outcome measure if we're talking about a lot of these new treatments. Most of them, well, all of them will work. We can see that from some of the slides that Nikki has shown. And so really what needs to be taken into account here is actually what benefit does that have to you as the individual taking them, if you're then less required to come to hospital, less time in hospital, and so forth. And unfortunately, I think it's fair to say that the ability to capture that information in clinical studies is often quite limited, or at least historically has been. So I think this all leads on to the question, doesn't it, how and where will care be delivered? And so we've got a few examples, and probably many of you now are communicating sometimes with your Haemophilia Centre by a telephone review, so this doesn't project very well at all, as you can see, but basically during COVID we had to change our ways and start to use that old bit of equipment, the telephone, a bit more. And so there are various examples of what's been published experience. This is on the one hand from the Republic of Ireland, on the other hand from Northern Ireland. But the overall point was, when they looked at people's experience, both the clinicians and the patients, many people, and the majority, found that some sort of virtual consultation was beneficial. And you can imagine that, can't you? Because if you've got no problems in the preceding 6 months or year, and you then traipsed to the hospital by some form of transport, and if you decided to park, then took half the day to park, it's not really very useful to then come into your appointment and say, is everything okay? Well, yes, it actually is. Well, that's very good. Goodbye then. And we'll repeat this exercise in a year's time. So really, these sorts of things have already come to the clinical area and perhaps will increase in use as time goes by. So we've obviously got the telephone, my favourite old bit of equipment. I wish everybody else used it. And then online consultations, although I have to say that we must acknowledge the vagaries of internet access in the health service and the inability for us to communicate with each other on Teams, let alone with somebody outside of the organisation. So I'm not so sure about that. But I think the idea about apps, provided, of course, the app is working and you've got access to your internet, actually has some advantages, because we've got HaemTrack already for people on prophylaxis and people putting in their treatments, and again, I'm sure it's used variably, but we use it a lot in our clinic, where we look back at the HemeTrack records and we can identify areas where we need to discuss things before somebody comes into the consultation. And then if you've got your own ability to update your records, it comes back around to that personally held care plan, doesn't it? In theory, it should be possible for people to start making their additional notes, and there are examples from other areas of healthcare where that happens. Could we have some real-time messaging via an app? I mean, that's something, again, some areas of clinical care offer, some GP surgeries offer it, particularly some that are in the private sector. And then we come on to this, perhaps, holy grail in bleeding disorders of self-monitoring. So perhaps we could end up in a situation in the longer term where actually you're doing your own monitoring, you're essentially initiating a consultation if there's something for you to actually discuss. So you could say, well, I'm going to forego my appointment at the moment because everything is okay, and yet when there isn't something that's okay, or there's an issue that's arisen, then you could be asking for a discussion then. Obviously, that's quite an aspiration, isn't it? Because the difficulty we've currently got is having capacity to see people who need to come to clinics. So if we've got a situation where people are initiating an appointment themselves, then they're going to have that facility to be able to be seen promptly, rather than waiting many weeks for that answer. But I think these aspirations aside, ultimately, we do need to try and reduce the burden of travel for review. Now, this is a list of the current comprehensive care centres in the UK on the left, and then on the right, the treatment centres. So there's quite a lot of different centres covering lots of parts of the country, but obviously the geography is quite a bit different, and if you're down in the southwest, travelling from even Truro, for example, to Plymouth or to Bristol, if there's something you need to access there, is no easy undertaking. So this leads on to networks of care, and that's something that Will sort of alluded to with the service specification. And these already exist in some parts of the UK. So in Wales, there's been networks of care for a number of years, similarly in Northern Ireland, and in England, just as an example, Hampshire. And what would be the main objective of that and benefit of it? Well, obviously that would be to reduce variation. So if we've got a situation where there's, let's say, a hospital that doesn't have a treatment record that's accessible in the emergency department, well, hopefully by being part of a network, you then have that common sense perhaps disseminated around the network with some structure. Staff who then rotate around in the hospitals within that region might become familiar with things, and then you'd reduce some of the difficulties with accessing care that people continue to experience. I think the other thing is we need expertise in other specialties, though. We've talked about accident and emergency and bleeding disorders, but actually orthopaedics and gynecological care for women with heavy menstrual bleeding, for example. We need those other specialties to have perhaps sometimes a different approach. So it's no good, for example, saying to somebody, you can't have procedure X because you might bleed. Well, any of us might bleed. So if we're saying that we can't do this in somebody, what we're saying is we can't get the right advice, put the right monitoring in place, and give the right treatment at the right time. And so if we take away some of that concern that's an impediment to having certain procedures, then actually that would again benefit everybody. And I think Will talked about variation in the UK HCDO report, NHD report from last year about the use of current treatments we've got. And then we were talking on the panel, Joe mentioned about people not being aware of the trials that are available currently for von Willebrand's disease, and perhaps a focus on centres that have got a greater group of patients with a variety of conditions, and then not being overlooked then with those centres with less patients for undertaking those clinical trials. So if we've got networks where everybody knows what's available in the network, then again access to trials, if that's appropriate, and perhaps more importantly, access to newer treatments as they become available might also improve. And I come back around to that thing again about care closer to home, and better sharing of knowledge, because I think as much as you want somebody who is knowledgeable about your condition, and we've tended in healthcare to centralise that in a few hospitals, as we described earlier, actually we've taken away the skill and knowledge whatever that might have been, from your local hospital sometimes. And so we're increasing the circumstances in which you're going to encounter somebody who has never seen a condition, and perhaps more importantly, because they're not seeing rare conditions regularly, so they're not thinking to themselves, I need to use that old bit of technology, the telephone. They don't have that awareness. So if we start to make it more routine that people are seeing people with a variety of conditions in their local area, GP surgery and similar, for example, we might start to improve some of the awareness. And this comes back down then to upskilling everybody involved in care delivery, whether it be the actual haemophilia staff or, more importantly, perhaps those outside of the haemophilia service. And this leads on to some of the things that we need to think about from an NHS perspective. I think in that succession planning, maintenance of skills and the staff we've currently got. But actually, do we need always to be having doctors involved in these reviews in the clinic? Not really. There's clear roles for enhanced care with nursing and physiotherapy. Do it, for example, prescribing and then running clinics. I have my former physiotherapy colleague from Swansea who has gone on to do great things with her career and is an individual independent prescriber, and runs clinics herself. And so actually she can do a one-stop shop for you. You can go along to her. She can review your prophylaxis, review your prescription, go through your joint problems, talk about mobility and so forth, and actually deal with a lot of things in one go. And I think ultimately what we have to hope that this will do is that everything is better linked within the region. Hopefully there'll be clear commissioning of services to facilitate delivery. And I think one of the things that's not been done well is involving patients in planning the services that we've got. And we've all got our desires of what we would want to be able to access easily, and there's always going to be a tension between what we would personally want and what can actually be delivered by the state ultimately, and we have to be cognizant of the financial predicament that we are in. Local guidelines and pathways of care may help, and ultimately we might improve education events rather than the ad hoc things that happen now, both for people who are using the service and for staff. In terms of reviews, I think we very much need to get away from a lot of medical direction, and then physiotherapy, psychology and prevention of other health problems then become important. And this is where the long-term NHS plan comes in. So it's got three quite noble objectives, and how would we think about that in the setting of bleeding disorders? Because if we're changing the treatment so that you don't necessarily need to have such regular review at the Haemophilia Centre from a bleeding perspective, how are we going to make it potentially more productive for you if you are coming to the Haemophilia Centre, and what can it do to improve your care and health beyond bleeding? And so this is one of the, I suppose, the key things for all this treatment innovation. If we don't think about things beyond bleeding, then we're not going to really realise the advantages that these new treatments are going to offer in terms of quality of life. And so, briefly, we'll just think about some of the things that we could think about, and that's cardiovascular disease, diabetes, bone health, and then psychological well-being and exercise. And I thought we'd start on a high, and that is with cardiovascular risk. So this is actually observed events in this quite large study from the Netherlands. So if you look at this group of individuals with haemophilia A and B, this would be their calculated risk, and this is the observed number of events with the treatments we've had historically. And I say that because actually if we start to rebalance or normalise hemostasis, then okay, it may be that these actual cardiac events are fewer historically because the clotting factor levels have been lower, and therefore your chance of blocking off your artery in your heart is less. Actually, as we change treatment and perhaps more normalise hemostasis all the time, then we might start to see that increasing. And indeed, I don't expect anyone to really attend to what these things are, but basically the dotted lines at each side are the reference range for the population, and these are people with haemophilia as they're getting older, and this is the amount of calcification in their coronary arteries, and this is thickness of their carotid arteries. And basically, although the events might be fewer, the actual underlying problem that will cause you to have a stroke or a heart attack is there, just like it would be with your peers. And so it's the only reason the events are fewer is because you are deficient in a clotting protein or have something wrong with your platelets or similar that protect you from the manifestations of that. So if we correct all of those manifestations, then suddenly all of this becomes an issue. And then we go further downhill a little bit with high blood pressure, and this is a study from the US. Again, it's not presented very well here, but basically you have people of all age groups, this is again with haemophilia A and B, compared against a national survey in the US looking at nutrition. And for all age groups, essentially, people with haemophilia, and you'll have to imagine where the line should be, actually have got a higher frequency of hypertension. And then actually the problem is the number controlled, and again this is the lower bit, imagine where it might be, had it projected correctly on the screen, then fewer have got control of their hypertension. So there's lots of different reasons why that might be. We can think about historical issues relating to the treatment for blood-borne viruses, for example. It'll certainly perhaps be increasing risks in the older group of patients. But perhaps what this is really telling us, we're all, both the people who use the service and us providing the service, so focused on ABRs and similar, we're forgetting other issues with our health. And in terms of bone health, and which is, I suppose, a corollary of exercise, again, people with haemophilia tend to have a higher risk of having reduced bone density. So we need to be addressing something there. But on a positive note, with diabetes, if you look at the red lines, which are people with haemophilia, again a study from the US, and the other groups are veterans, and then that national survey, the NHANES study, basically haemophilia does tend to be relatively protective unless you've contracted hepatitis C. So, what can we say at the end of all that? Well, I think we need to have we have to accept that the process for approval of new treatments has changed, and it's going to be there for the foreseeable future. We need to be thinking, I suppose, when we're talking, it sort of intrudes a bit into what Nikki was saying about how clinical studies, and if you're involved as a patient giving feedback to companies that are going to be doing the studies, how are they going to collect meaningful outcomes for your experience and what you'd like to see from treatment? Because without that, the cost-effectiveness issue is always going to be challenging. Hopefully, the service specification will better support networked care, and I would really hope that the ultimate shape of care in the future is that people are being looked after closer to home, with less need to traipse to the haemophilia centre, and perhaps the broader attention to wider health concerns beyond just bleeding and the associated complications. Thank you very much.
Thank you very much for that. That was excellent and very entertaining. Can I invite the other panellists to come and join us? So I think, Will, you can come back up. We've got Claire Lentane, consultant haematologist from Plymouth. We've got Susie Shapiro joining us, consultant haematologist from Oxford. Charles is going to stay here, and then we've got Joe, and we also, Joe returning to the stage, and we've also got Claire Harrison as well, our patient representative. Lots of questions from me, and I'll just pose one or two to start with, and then we'll see what the panel have got to say and open up questions to the audience too. I suppose first one, obviously EHAD and EHC have talked about the hub and spoke policy for gene therapy. Do you think there is an opportunity with gene therapy now to piggyback on the back of those networks that will be formed as a result of those to support the adaptation of the structure of haemophilia care, and how do you envisage that happening? Who wants to take that?
So working, yeah. Well, there is in fact, as a direct consequence of the IBI recommendations, a draft specification for haemophilia networks kicking around. And I'm very pleased to say, Charles, I don't know if you had a sneaky look at the draft of that, but your presentation almost perfectly matched that.
Complete coincidence.
Yeah. And they will be based on the adult comprehensive care centres, and with a separate paediatric one. Now, this hasn't been signed off yet, and we've already put in a request some funding for this. And I'm fairly optimistic, although I've been broadsided by that in the past, but I'm fairly optimistic given that it is a direct consequence, a recommendation from the IBI. So I'm hoping that we will in the future have funded networks, and that, like I say, there's a draft spec, and if it does proceed, it will go to stakeholder testing in the not too distant future, I would hope.
Great, thank you. Charles, you touched a little bit on the end there about ageing. Many of us with haemophilia now have the privilege to age with this condition, which is a privilege that's been denied to many over the years. How do you see the ageing piece fitting into the structure of care? Obviously, we've got an updated specification coming along, but that's going to have to evolve, isn't it, as people get older in terms of being in care homes, all those sorts of things, and with all the novel treatments we've just been talking about earlier.
Well, indeed. So I think it obviously provides a lot of opportunity, the treatments we've discussed. I think that the reality is, as haemophilia treaters, we're very adept at dealing with bleeding disorders and complications of that, or at least hopefully we are, as some of you probably have mentioned, but not always. So it's going to require quite a different skill set to address the breadth of health care, because what we're talking about, I suppose, here is in some ways substituting and supporting what would otherwise be the activities of primary care. And so I think that the opportunities there probably are around upskilling our non-medical workforce. So a lot of healthcare in primary care that is preventative is delivered by nursing teams, and there are already examples within the UK, so Northern Ireland, for example, Newcastle, to name but a few, where the clinical nurse specialist team have taken that on and proactively address cardiovascular risk, osteoporotic risk, and so forth. And actually, on the subject of social prescribing, there are some novel solutions around psychological well-being that, for example, in Northern Ireland, I know they've used, where they've used gardening and horticulture as a vehicle to try and improve activity, diet, and also a feeling of community and reduce isolation. So I think we need to be cognizant of what we don't know as haemophilia doctors and concentrate or think about how we upskill the wider team.
Claire, could I ask you a question on that then? How do we re-educate patients? And is that something we need to do in the sense that as patients, we naturally gravitate towards our haemophilia centre, even if the issue isn't bleeding disorders related? That's often our first port of call. That obviously, as the years go by and time goes on, will create a greater burden and strain on comprehensive care centres. So how do we manage patients' expectations about what their comprehensive care actually is when they go to the centre, and what, more importantly, perhaps what it isn't?
So I think that as a patient, we always will gravitate towards the medical team who we are most easily able to contact and who we know the best. And I think one of the reasons, perhaps, maybe better for a patient to say this, but I wonder if one of the reasons that people gravitate to their haemophilia team is that it's a lifelong relationship. We know them, we know our patients know us very well. And I don't necessarily think that's a bad thing, but I think that we can then signpost patients and to the right teams. And I think that's another reason why the working as a network is going to be hugely beneficial. I am a big fan and a proponent of the network working. A lot of us work in networks in the UK, but it's very clear that the networks work differently across the UK, and it's important to kind of try and standardise that and bring everybody up to the same level. One thing I would caution against, and I think Charles also alluded to this, is the sort of continuing a hierarchical structure. So caution against perhaps the use of terms such as hub and spoke and the hierarchy of comprehensive care centre and haemophilia treatment centre, which has its use but can also be slightly harmful. So I think working as a network is better, because you're not always, even in your comprehensive care centre, going to have the expertise from expert cardiologists, neurologists, renal physicians, whichever other teams you have. So actually working as a network probably opens you up to expertise from other specialties in other centres. Also, particularly, I think if everything is always commissioned through a comprehensive care centre, You can disadvantage patients who don't live geographically close to the comprehensive care centre. So, for example, in the southwest where I work, some of my patients live several hours from the comprehensive care centre, and they want their treatments, they want their operations to be close to home. If the psychologists are commissioned through a comprehensive care centre and that's where they're located, even with modern technology, you potentially disadvantage the people who don't live close to that centre. So I think working as a network and commissioning services through networks perhaps offers better equality for all patients, no matter where they are living.
Want to ask a question there?
I just want to jump on that point because I think when I came into haemophilia care, the idea of a patient with a severe bleeding disorder having, for example, a surgery anywhere other than the comprehensive care centre brought everybody out in a rash. I mean, the clinicians and the families. And I think now, I mean, particularly since COVID, and it's a function of all sorts of NHS-related things that none of us have control over. But for example, one of the hospitals I work in essentially no longer does routine orthopaedic care. It's farmed out to another associated district general hospital where they have no experience at all in doing surgery and bleeding disorders. So there's this sort of catch-22 of, no, you can't do the surgery here, but no, we can't manage the bleeding disorders care there. And it's forcing all of us to sort of change the way we look at where surgeries can be done. And I think particularly with the advent of very long-acting factor VIII, what Charles was alluding to is somebody needing a knee replacement, potentially the whole anxiety about that person needs factor VIII levels twice a day, they need injections 3 times, you know, maybe they're going to have 1 dose of factor and go home 3 days later like everybody else. And so I think that there are some new possibilities that will fit in with all of this and make it possible for some patients to have care nearer to home. And I will leave it with just one of our colleagues in Hampshire who is the clinical lead for the Southern Haemophilia Network. And I think she puts it beautifully, which is care locally where possible and centrally where necessary. And I think that kind of sums it up.
Yeah, very good. Anybody else on the panel want to comment at this stage? Pass on. Claire.
Anyway, interested in what you were saying there. I mean, I come from Birmingham, so the care is very good for my son in Birmingham. Unfortunately, we are not supported locally. We live in Sutton Coldfield, so we're lucky that it's not too far. It's only about 25 minutes, half an hour, but we have to go to Birmingham, so we are not supported anywhere but at the Children's Hospital. And considering that is it is a very good hospital, I can't fault it. We don't have any other options. We have to go to centre. I'm kind of deviating. I've got a question because my son is coming up to 15, and I'm quite concerned about transition and equality for him of care going forward. What that's going to look like. He's obviously going through puberty, and boy, it's fun on so many different levels. So we're going through no, I'm not doing my treatment. So we've got the puberty, you know, that kind of thing going on. But for me now, having to battle that, and have you been, because he takes himself and they're battling the whole, encouraging him to self-administer because he goes weekly. He's now doing the whole he's not going. So I'm trying to find out whether he goes. My concern now is when he transitions, say, to the QE, is, you know, you're 1 step removed. So I'm quite concerned about, you know, what does transition look like? When do they do it?
We can just pick up the phone to Charles.
There's happily a process, which hopefully Natalie will go through with you in the BCH before he comes over. But I mean, I think that is a challenge, and I think... So when I was a consultant in Wales, we did whole-of-life care, and there can be, you know, arguments about that, but actually I think that's helpful because you haven't got this transition barrier. I think that this comes down to psychological support as well, because that's perhaps the thing that has been massively lacking Fortunately, we finally are awash with psychologists in the QE, so that's a good thing. But it's taken 8 years, or over 8 years, to sort that out. But I think that that situation is not unusual. It's always going to be a problem of teenage years, isn't it? And it doesn't just happen in bleeding disorders, it happens across all health conditions. And even if you haven't got a health condition, there's a challenge. So I suppose ultimately having better knowledge within hospitals he might go and access, because he might end up going to A&E somewhere, for example, mightn't he? This is where networks of care become important, to try and facilitate somebody who, if they're not confident about accessing their care, or they understandably have some reservations about dealing with things, they're then facilitated and supported by the hospital structure. But that's a long way off ultimately. So I think for the time being, that sort of situation is best dealt with through clear processes between the local hospital, where he's being looked after with from a paediatric perspective, then the adult hospital, and then psychological input later on as needed, basically.
Linking back to Nikki's presentation from the very start.
It just demonstrates, doesn't it, how the treatment needs will change through someone's life. And dare say that, this particular point in time, 15 years old, that transition from adolescence to adulthood, is one of those critical points where treatment needs and demands will change, and therefore needs probably a review in that respect.
Yeah, sorry, I feel like I'm hogging the mic today. Going back to, so talking about quality of care and treatment, is that he's gone from on-demand to weekly prophylaxis to 2 weekly prophylaxis to now they're talking about subcut, because he's not going well with the self-administering. So, but the hospital have talked a lot about you can't keep changing treatments because of inhibitors. So it was it felt very positive. Then all of a sudden I felt very quite fearful, and then kind of came away feeling quite unsure as to what because they said that potentially they're a centre that's going to be doing it, and then potentially he's going to be in the bracket as also for gene therapy. So it'd be interesting to sort of hear and understand. It's knowing where the information is, because I had to push and to find out. So I only knew that from the Haemophilia Society. It was only by going to the conference that we had. That was it, the big get together. On the back of the conferences, I asked about treatment. Otherwise, I wouldn't ask.
I think the Haemophilia Society, on the subject of gene therapy, there is an excellent information leaflet there, and I think anyone who is considering gene therapy, it's a good place to start. Obviously, there are nuances depending on the condition. There's differences between haemophilia A and B gene therapy, as Nikki mentioned. So I think this is, again, when we're talking about networks of care, it's about ensuring that everybody in the network is, in terms of the hospital structure now and the staff looking after somebody, are aware of what's available within that network, perhaps in clinical trials, for example, and also in terms of attendance at national meetings. We have UKHCDO meetings regularly, but not everybody's going to be able to attend those. But if you have somebody from within the network attending, it's a way of disseminating that information out to those who couldn't. So I think from a clinician point of view, that's the way of disseminating that information. But in terms of how you approach, I suppose, as somebody accessing the service, one of the things I didn't mention with telephone consultations and virtual consultations, again, there's a checklist on the Haemophilia Society website of the questions you might want to prepare yourself for beforehand. And actually, that's probably a good thing before a consultation in person as well, because if in the heat of the moment, you've struggled to park, etc., are you going to remember all the things you wanted to ask? And unless in a structure in the clinic, the clinician, whether it be a nurse or doctor, is going to actually raise the question about new treatments, then you're not going to have that conversation. So I can only give examples from what we do in Birmingham, but in the Queen Elizabeth we always have treatments on the horizon that we discuss where they're available. And so that's just our structure of our consultations. But would that be the same in a different hospital? Probably it may not be, and therefore this is again why we need better networks to disseminate better approaches.
Thank you. On the topic of telephone consultations. I have a few concerns in terms of telephone consultations as a patient, but also a patient advocate, because I hear lots of patients who come to me, and particularly women who are suffering with severe menorrhagia, who could have 3 weeks a month where they're bleeding and bleeding heavily. And when we have a conversation and I say to them, do you not raise this when you're in your clinic visits? And they say, well, I don't do clinic visits because I do online consultations. Online? Well, no, they ring me. So, okay, they ring you. And at that point, do you then have that conversation? Well, they usually say to me, is everything okay? And I usually say, nothing's changed. Well, that is an ongoing problem because they aren't sitting in front of somebody. They haven't had their bloods done for 5 years. And this is a young woman who was talking to me, type 2 VWD, and is literally, this is having a huge impact on her quality of life. And yet she thinks that's something, and she said the last time I did sort of mention I had heavy periods, I was told that will be your VWD. Now, that is just telling her that's your bleeding condition, and actually that's what you should expect. But we shouldn't, as patients, be accepting that that should be the quality of life. And I think that that is particularly problematic when doctors and consultants are never actually having conversations face-to-face with somebody and potentially looking at them and thinking, goodness, you look terrible because you're clearly anemic.
Yeah. I'm not sure the problem is the medium there. I think the problem might be the nature of the question. And it's quite a leading, or dare I say, closed question, and perhaps a more open question. So there's perhaps an element where people need to just stop and think about the nature of the questions being asked. But the other thing I was going to say, Joe, is that a patient diary or some sort of record, if that can be shared, that's usually, to see it in writing or in front of someone, even if it's, if it's a remote appointment and it's kind of scanned or whatever, photographed and shared, that's very objective information which it's not easy for any other person to kind of ignore or maybe not pay as full attention to. So I definitely would advise keeping a little patient diary or note to show how they're feeling day to day or what the extent of the menorrhagia is.
Susie, I'm conscious you haven't spoken. We've only got a couple of minutes left, so I'm going to hand
That's
over
fine. I can always speak. Well, I guess it raises two things, doesn't it? I think as women, we normalise heavy menstrual bleeding. So that's one thing that there is a lot of discussion about at the moment to how not to do it. I think from the point of view of in-person compared to virtual video compared to telephone, ideally it would be patient choice. So historically we always brought in everyone with moderate or severe bleeding disorders every 6 months and other people every year as a minimum. But not everyone wants that, because if they are genuinely well, they don't want to travel 2 or 3 hours to the centre in order to come in person. And so since we were forced to do different things in COVID, actually, certainly locally, we now give the people who we know are doing well or who we believe are doing well, the option. So of face-to-face alternating with telephone clinic and at least coming in every few years for bloods. But it is reliant on that discussion of what are your periods like, any bleeding, etc. If you're worried, come in earlier. So yeah, that's part of that. And going back to you, Claire, because there's an awful lot in what you were saying. So just two things quickly. I think it highlights partly transition. So not sure what happens at the QE, but there's likely to be a transition program. So certainly, again, locally we do something called Ready, Steady, Go Home that can start from as early as 12 years old. And so it can be you, we can talk about it later, but it can be you and your son in the paediatric clinic starting this and going through the questions, and he gradually, they check his knowledge, And then when you come to that adult centre, often both of you for that first appointment, we give one to each of you. So one to your son and one to you to check where you both are. And often the conversation at that time is quite helpful. And the other thing I was thinking when you were saying that he was slightly bombarded, or almost like feels like a bombardment of treatment options, is that is one of the challenges about the new treatments. So if he is doing well, there is no urgency to treatment. Obviously, if he's not, there is more of an urgency. But I think it highlights the challenge in how to go through effectively the different options, and whether it's us talking, whether it's videos by the Haemophilia Society, whether it's another way, I think we've got to improve how we go through all of those options. And to reassure you, if he is doing well, it is not urgent. So many of the discussions we have happen over several years in different clinic appointments.
Brilliant.
See, I talked enough, right?
Right on 3:10, and I don't want to keep anyone from their coffee. So thank you very much to all our panellists. Thank you for the excellent talk this afternoon. We've now got a 20-minute break for tea and coffee. I think coffee's being served back outside in the atrium. Anyone looking for the toilets as you go outside, they're down the stairs there. But if you can be back here in 20 minutes for our next session, please, which is what keeps me awake at night other than caffeine? Okay, welcome back, everybody. I know a few people are just still wandering in, but we'll make a start back. Just one brief reflection, if I may, something I wanted to try and mention earlier. It was that was really interesting, Mary, what you said about treatment options and talking about different treatment options at different stages of life, because I think as a patient organisation, certainly Kate and I and other members of the Haemophilia Society team, for many years, when we think about what as we as a society can do, we find that there are often touch points. We talked about haemophilia and bleeding disorders being lifelong conditions, and we find that people's desire to engage with us will wax and wane depending where they are in their stages of life. So I found that fascinating. You talked about the fact that we now need to start talking to people about treatment choices at different stages of life, and certainly if I ever considered having gene therapy, it would be for a particular reason and maybe for a particular window of opportunity. I know some people might consider it, for example, when having children, or thinking they might want to go off travelling after university, those sorts of things. So I think that's a really interesting takeaway from today. Anyway, I am talking, and I shouldn't be, because we are about to start our, effectively, what's a bit of a fireside chat about what keeps me awake at night. I can tell you that my arthritic ankles and my elbow, which I can't quite straighten, that keeps me awake at night, along with the guttering outside my window, which I only ever remember when it rains. So I'll go home and remember that keeps me awake at night. But enough about that. We're now going to have a discussion between Mary and Susie about what in particular keeps you awake at night. So over to you.
Shall I get down from the stage? Hello, everybody, and thank you to the RSM and to the Haemophilia Society for asking us to be involved with this, which has been a really interesting and stimulating afternoon. This is me and where I work. These are my disclosures, but also Charles has reminded me to point out that in addition to this, I'm the current secretary of the UK CDO, and I'm the chair of the Paediatric Working Party. So I'm going to focus on three things, but essentially really on one big thing. And before I start, just to say, as Clive mentioned, really what keeps me awake at night is poorly timed coffee. Mostly, I think we are able to achieve excellent bleeding disorders care in the UK, and I hope that remains the case in the future. I think it is world leading. So anything I'm about to say, which is a bit sort of doomsday-ish, please take in that context. So one of the things that concerns me, and Charles has alluded to it, and will probably give me a forward defensive in a minute, in contradiction, but is how new treatments are assessed and commissioned in the UK at the moment. So there has been a change over my sort of treating lifetime. And I want to put this in context of, in the UK CDO annual report for 2024, we identified just over 2,300 men and boys with severe haemophilia in the UK. And whereas in contrast, if you look at the Cancer Research UK website, they state that in each year, there are over 600,000 new patients with lung, breast and colon cancer. So obviously totally different treatments and conditions. But the point is that the standard of evidence required, to some extent, to get new treatments commissioned is the same for both of these groups. So that the absolute gold standard of a randomized controlled trial, one arm of patients on the standard of care, one arm on the new treatment, blinded to both the patient and the clinician, and then potentially crossing over to the other arm. That's not possible in bleeding disorders care. And I've only mentioned the number of severe haemophilia patients because it's the commonest bleeding disorder we look after. Imagine severe factor V deficiency. There will never be evidence that is good enough to compare with the evidence we can gain in cancer studies, blood pressure medicines, cardiovascular disease medicines. And I worry that if that standard of evidence isn't good enough, a time may come where new treatments are sidelined just because it doesn't measure up. Leading on from that, and again coming back to our patient with severe factor V deficiency who I've lost in the audience, but when we talk about rare bleeding disorders, what we're really talking about is ultra rare bleeding disorders. You have, those of you in the audience who have haemophilia, it is a rare disorder. But factor V deficiency in a severe form is probably not quite hitting more than 20 patients in the whole country. If you look on the right there, again, it's the UKHCDO statistics from last year for rare bleeding disorders. I don't want you to look at all of the numbers, but just focus on the factor X deficiency, for example. So in yellow, I've highlighted the total number of men and women who are registered with factor X deficiency. So, you know, it's over 400 patients, so rare, but not so rare. But in green is the number of patients who were treated in that year. And I can tell you, because it's what I do, that almost all of those will have severe factor X deficiency and they'll be on prophylaxis because it's a life-threatening bleeding disorder. No pharmaceutical company is going to be able to run an investigational medicinal product trial for that treatment, for that condition alone. So on the left, in the green hexagon, are the two rare factor deficiencies that have an existing recombinant treatment. And just to say, neither of those treatments evolved to treat those conditions. They were off the back of trials for other indications. And the same in the red are those rare factor deficiencies where there is only plasma-derived treatment. And this is now in a post-IBI world. We are looking, if you are born with one of these conditions, it is almost unthinkable that a recombinant product will come along. And do I worry about that? Yes, I do. And in orange, of course, are the severe platelet disorders, Glanzmann's and Bernard-Soulier, and we don't actually have a licensed preventative treatment for them at all. So how are we going to get the evidence to get new treatments for rare bleeding disorders? And I think the only way is collaboratively between clinicians, patients, pharmaceutical companies to look at some of the new rebalancing treatments coming through that may have indications for some of these conditions, and to try and collect that data in a way that we can feed through to the MHRA, to our commissioning colleagues, to say, look, here is some evidence. It's not going to be giant, but here is some evidence to try and move these treatment areas on. So for the remainder of my talk, and Susie's going to throw things if I talk for too long, I'm going to focus on inhibitors in severe haemophilia A. And I apologise because this is quite focused, but it is something that really worries me. So for those of you who aren't familiar with this, an inhibitor is simply the name we give historically for an antibody that's raised against either factor 8 or 9 when we start treating babies and small boys with haemophilia. So this can happen in haemophilia B. Fortunately, very rarely. It's extremely difficult to deal with. But in the majority of cases, it happens with severe haemophilia A. And when I say that, it's 1 in 3 of the boys that I start to treat will get an antibody. How do we get rid of them? It's something called immune tolerance. It's either steady, constant, relatively low doses of factor VIII every other day or every 3 days, or it is giant doses of factor VIII once or twice a day. And the choice there really has historically been based on how high the antibody level goes. So how we dealt with these before emicizumab was available and how we deal with them now, there's a big dividing line. So before emicizumab, we would start the babies, boys, on early factor VIII prophylaxis, certainly under the age of 2, and often in my practice under the age of 6 months. about 1 in 3 of them would develop an inhibitor. At that point, factor VIII no longer works. So you can't prevent a bleed and you can't treat a bleed with factor VIII if the antibody level is high enough. So at that point, we had no choice but to attempt immune tolerance. So that's a very labour intensive, it's a really tough call for the families. It's also very expensive. So at the end of that immune tolerance process, if there was success, those boys carried on factor VIII prophylaxis, and in my practice, most of them still are on factor VIII prophylaxis. And where it failed, and if you look at our national historical data pre-ME, we failed in about 10%. So about 90% of these boys we were able to achieve immune tolerance, but there was always a sort of hard core that we couldn't get rid of. And those boys, after 5, 6, 7 years of trying, we switched over to what were then the only existing bypassing agents, which saved lives but did not prevent all bleeding. So absolutely no comparison in terms of bleed prevention with either factor VIII or emicizumab. And apologies to Mr. Smith in the front row, I'm going to talk about annualized bleed rate for a short period of time. So this is just to give you an example of, not that probably any of you will need it, of how amazing emicizumab was when it came online for this group of patients. So this is our GOS data. The first 10 were in the Haven 2 study and the others got early access. These are all inhibitor boys. So if you just focus on the yellow columns, so the annualized bleed rate pre-emicizumab, and then next to it post. And this was an absolutely miraculous change for these boys and their families, not just the boys. And this is reflected also in school attendance, in a reduction in the number of hospital visits. No question at all that this is the best available treatment now for patients, adults and children with existing inhibitors where we couldn't get rid of them, no question. So, but just to say that non-factor treatments, and obviously emicizumab is the only one we have at the moment licensed and commissioned in the UK, are not the same for all age groups. So the patient on the left, the young man on the left, has switched to emicizumab in his 20s or 30s. He has been on factor VIII prophylaxis prior to that, and he's very able to treat himself. So he may, having post-switch, he may have had fewer bleeds. Perhaps he was on suboptimal factor VIII prophylaxis and his number of bleeds may have gone down, the ones falling off your bike, not the ones on the sofa. And he certainly has a reduced treatment burden, also no question about it. But he can give himself an extra dose of factor VIII when he falls off his bike, when he needs a tooth out, when he unfortunately has a bleed in the ankle that was never quite right to start with. My patient on the left, and just to say this is not my patient, this is a stock photograph of a cute little boy. Great news. He started his prophylaxis on emicizumab because, understandably, his parents were keen to avoid a central venous access device. So was I. It provides very good bleed prevention, but children will do things like run around and fall over and bang their heads, and they largely do it more often than adults. Largely. It depends a little bit on the age of the adult. And so accidents happen. Children need hernia repairs. They have to have a circumcision. They are going to need factor VIII treatment in their lifetime. There's no way anybody's going to get around that. It might not be in their first decade, but it's definitely going to happen. And when it does, this little guy can't treat himself, and neither can his parents. So they are taking him up to accident emergency, inevitably at stupid o'clock, probably on Boxing Day morning, to be confronted by a resident doctor who may not have all the skills and may not know how to use a phone. This is a scenario that I have been trying to prevent for the last 20 years. It makes me very anxious. And the other thing to say, which I don't have time to go into, and it's not just my practice, but all around the world, children's treaters are seeing an emerging degree of needle phobia in the emicizumab pups, previously untreated patients, and minimally treated patients that we never saw in our boys with factor VIII. And I know there are many adults with haemophilia in this audience that doesn't chime with. But in our practice, where we've used central venous access devices, the boys aged 6 and 7 are sticking their arm out, looking at CBeebies and not worried. I don't see that with the emicizumab little ones. So inhibitors, we're seeing far fewer of them since 2019. And our now retired colleague, Mike Macris, rang me up once and said, "Why are there so few inhibitors?" I'm like, "Mike, because we're not giving factor VIII to these boys at the moment." It's not that it's not going to happen. I think we're just kicking it down the road. So we know that there are modifiable risk factors for inhibitor development, bearing in mind that this is happening to 1 in 3 of these patients anyway, boys anyway. But the things that increase that risk are intermittent doses of factor VIII. You have a dose when you bang your head, you have a dose when you have a tooth out, you have a dose when you have your appendix removed. That's a red flag. Peak treatment moments, so you give 5 days of treatment for the bad traumatic knee bleed or the surgery, and an associated inflammatory response. They've got to bleed, they're having surgery. These are all things that we know increase inhibitor risk. And so my doomsday prophecy is that we're not going to see fewer inhibitors, we're going to see more. It's going to take longer to happen, but we're going to see a greater percentage. And there is actually already some suggestion of this in some data that's come out of Israel, where they've got a cohort of patients treated early on with emicizumab who've had up to a 50% inhibitor risk. Now, day to day, that doesn't change things, but as they go through their life, this is what I'm worrying about. So in a post-EMI world, you might not get an inhibitor until you're 10 or 20 or even older. Usually they occur around 10 exposure days to factor VIII. So at that point, it's a teenager. Where's the mum with the teenager? It's a teenager. It's difficult to get him to get in the shower and brush his teeth, yes? Going to be really tough to get him to start giving intravenous treatment when he never has, for example. So again, factor VIII's no longer going to work for that child. Are we even going to attempt immune tolerance? It's a big question. It's a big question because it's a big ask for the family, but also it's a huge ask for the exchequer. When I'm giving immune tolerance to a child who's 6 months old, that's not a lot of factor VIII. When I'm giving it to somebody who's 16 and 70 kilos, that's a big ask. If we don't attempt ITI, then we're left with possible response to factor VIII. If you give it once every 5 years, they might get response to 1 dose. After that, the antibody level will go straight up and they won't work at all. Or do you just say, we're not going to attempt factor VIII, we're going to manage all of the extra treatments, so the trauma, the surgery, the bleeds, we're going to use what would be recombinant 7A, in the future possibly alternatives. So if we attempt immune tolerance, what might it look like? To start with, you're going to be looking at a group of haemophilia treaters who aren't experienced in this. This is what I've done every day for the last 20 years, but my adult colleagues have 4 patients with inhibitors at the Royal Free. This is not what they used to do. They're not used to handling surgery and they're not used to immune tolerance. You've got a 14-year-old, possibly quite a high-level inhibitor, because maybe we're not going to be so good at monitoring for this because we're not really going to be so worried about it because emicizumab provides such great bleed prevention. So you get a high-level antibody. The only way to get rid of that is daily treatment. This 14-year-old can't treat himself. His parents can't treat him. He's 14. He's not going to be wild about this in the first situation, and he may not see the reason for doing this in order to give him all the options for treatment as he goes through life. I think that the chances of success in this situation are very low. So I will finish on a depressing note before I hand over to Susie, say that I think that this is a perfect storm. I think worst case scenario, we're going to hand on to our adult colleagues a cohort of young men with no venous access skills, possibly, probably some quite traumatic memories about venous access because they haven't had to do it very often, and either no or a very limited response to factor VIII, and all of the comorbidities that Charles and Nick have talked about as people get older, because you know these guys are going to get cardiovascular disease and cancer, and they're going to have traumatic injuries, and in addition an increasing thrombotic risk as they get older. We're adding a bypassing agent to emicizumab. We know that that balance between clotting and bleeding can tip a bit too far in the other direction. I will stop now, but just to say, whilst I see this as an anxiety, I also think there is a way forward, which we can talk about later.
Great, thanks, Mary. So hi, I'm Susie Shapiro. I'm an adult haemophilia consultant based in Oxford. So we decided to do a double act. So I'm now going to talk about what keeps me awake at night other than transitioning Mary's patients. These are my disclosures. So, sustainability of good quality care. This is not specific to haemophilia, but haemophilia is not exempt. I'm currently head of department for about 50 people, a few doctors, mainly nurses, quite a lot of admin and clerical, specialist lab. Our service only functions because every single one of them works hard and works above and beyond. The NHS has been very reliant for a very long time on people working above and beyond for the best of their patients and trying to deliver the best care. And it has become more and more difficult over the last 10 years, and particularly in the last 5 years since COVID. And most of my staff are somewhere along the edge of being broken. And that is genuinely what keeps me awake at night, in how to hold our department together, in how to keep staff, retain them, to try and bring joy into the work when everyone is so stretched, and when staff leave, when the hospital may not replace them because they need to save money. And so that I do not have the answer to, but it is an incredibly difficult place to work at the moment. So someone who loves the NHS and loves my job, but it is very difficult. The other thing that has definitely kept me awake, particularly at different times over the last few years, is trust and partnership in the light of the infected blood inquiry. So this is clearly going on for a very long time. The infected blood inquiry has brought many emotions to the surface, and I very much hope will have a positive legacy. But I am very aware that we cannot expect the trust of our patients working within bleeding disorders. For as many healthcare professionals, patients might go and see them and they kind of will trust whoever they are seeing until that person doesn't behave or doesn't do something that they want. We don't have the luxury of that within bleeding disorders with all of our patients. Everyone is different, but we very much have to be mindful of this and be conscious of working to keep trust or to make trust. And good care going forward will only work if we can successfully do this on both sides. Okay, so then the next bit, they keep me awake at night less, which is good, but which is address and recognise knowledge gaps. So it's stuff that we know that we don't know the answer to, which is a challenge, but there are positives and we are working towards it, which is why it keeps me awake at night less, because it's kind of easier than the first two. So the first one I'm going to concentrate on is our ageing population with bleeding disorders, including cardiovascular disease that Charles talked about earlier. So as we have an ageing population with bleeding disorders, and more we're seeing people who are having angina or heart attacks or irregular heart rhythms and maybe getting a stroke because of that. And the standard treatments if that happens to someone in the general population without a bleeding disorder is they're given antiplatelets, antithrombotics to thin the blood. So if it happens to someone with haemophilia, or another bleeding disorder, where is that balance? Because we spend the life up until that point saying, don't take aspirin, don't take ibuprofen, and suddenly we say, actually, you've had a clot, you now need to have something. Or another challenging scenario is someone who hasn't yet had a clot, but may be at risk of having a clot. But how much risk of having their clot, and where is the balance? So about over 5 years ago now, there was a James Land Alliance priority setting partnership, which was in the UK, but was the first in the world to do a really robust priority setting partnership between healthcare professionals and patients. And we got the top 10 priorities at the time and the top one was how can we balance the risk and benefit of antithrombotic treatment for cardiovascular disease in patients with bleeding disorders. And so what I just want to highlight is, having gone through that process, we have listened and are responding. So the UK HCDO set up a comorbidity working group, and the first thing we did with that was a review of the literature around heart disease and bleeding disorders to see what was out there already. And then what we identified from that is that we thought that the biggest knowledge gap was in atrial fibrillation, which is an irregular heart rate, for which most people are given something to thin the blood to reduce the risk of getting stroke. And we don't know enough about that in people with bleeding disorders. And so we have just started to set up a national registry of this in order to gather data prospectively to get a better idea of what is the stroke risk in people with bleeding disorders with atrial fibrillation, what is their bleeding risk if we start them on something, and to collect that data over time with patient consent to know, not immediately, but in 5 years, 10 years, we will be able to counsel patients better than we can now. And just the CASH study, because I'm quite excited. So this stands for Coronary Artery Care in Haemophilia Studies. So this is a study I have just initiated locally. We opened last week and have recruited our first participant earlier this week. So this is, Charles mentioned that we think, based on quite poor imaging data from 10 years ago, that people with bleeding disorders have similar atherosclerosis to the normal populations. Their heart vessels fur up to a similar degree, dependent on risk factors to the normal population. But it wasn't great imaging, and so what we're doing locally is we're going to recruit 80 patients with haemophilia and look at their cardiovascular risk factors and do some bloods, and then with a new state-of-the-art CT scanner, which uses relatively low-dose radiation, we will get really good imaging of the heart vessels and the fatty inflammation around the heart to help us answer that question with a bit more detail. And also the Haemophilia Society have been working over the last year or so on lots of patient information leaflets about aging in general, but including cardiovascular. So there's a whole lot more that we can do, but we are making steps to answer those questions. A couple of other very obvious knowledge gaps is women with bleeding disorders. We've talked about it a bit today, and so my colleague Nikki has been leading a UK HCDO working party. Within the last few years, we've published joint guidance with gynecology around heavy menstrual bleeding, and they're now also exploring a national registry to get better data similar to the one that we've set up for cardiovascular disease. And there is increasing education and attempts to increase the awareness around this. Bleeding disorders of unknown cause, it's kind of shot up in kind of what we're talking about massively in like the last 10 years or so, really, hasn't it? So there's still limited data around what we should be doing. There's international guidance, of which there were a couple of members from the UK involved in, that's been published in the last few years. And there is a UK funding request for a clinical trial to try and delve into the mechanisms that might be contributing to it. So again, there's work going on in that area. One knowledge gap that I didn't put in here, because it's not really a knowledge gap, but we might want to discuss about it later, is using, I think, a lot of the new treatments that we have, as we know from Nikki's talk, are around severe haemophilia, which is phenomenally exciting for severe haemophilia care. But there is a deficit not only with other bleeding disorders, but also for those people with moderate haemophilia and mild haemophilia, and really understanding what different people want within that, and then repurposing drugs that we know work very effectively in severe haemophilia and would work very effectively in moderate haemophilia, but maybe have not been licensed for that, or have been licensed and we don't have NHS funding. And that's even more difficult for the rare bleeding disorders. But I think one of the things I'd be interested in this group is for us to try and plan for the repurposing of some of those new treatments for other reasons, and how best that we can do that as a group. So, it's kind of coming more to my summary. To address service needs and future planning, we need to know our current needs, and we've got a much better idea of that through our recent peer review that have gone through all haemophilia centres.
We also need to anticipate how it will change, both for staff and for patients. And so we've heard many of the ideas that we're aware of already today around the treatments, around the aging population and the different needs, technology beyond the telephone. Also, like, there is the potential for artificial intelligence in simple things such as dictating clinic letters or dictating a discharge summary to save clinical time to free up for other tasks. But there are potential much more complicated things that it may be able to help us with. And patient expectations, with changing in treatment, changing with age, and changing as life and technology and other things change. I've talked about I've written the Bleeding Disorder Alliance, and I think that is newly established again. It had been present years ago, but basically that is an alliance of professional and patient organisations in bleeding disorder care. So the doctors, nurses, physio, haemophilia organisations, and also the Haemophilia Societies across the devolved nations coming together with one voice. And that voice, with us all speaking together, has the biggest impact. We also need to work very closely with the NHS. So NHS England here, but all the devolved nations, for that voice to be heard, for us to try and maintain the service that we currently have and to improve it. And that partnership and ensuring there's a really good understanding is crucial. And also industry. Because industry not only is bringing these novel therapies together, but also it can help fund some of our other studies to fill gaps in the area, such as my CASH study, to help us understand unmet needs. So that it's got a broader role with suitable ethics in place. And staff, I think, will need to adapt and will need to be dynamic and strategic and be resilient. So just bringing it all together, there's treatments and there's novel treatments and patients accessing them and being able to individualize care at different points in the pathway. There's ensuring that the staff remain there to do the service with the treatment and somehow ensuring that that whole service keeps on functioning. There's networks of care across the UK to try and ensure that no matter where you are in the UK, you will receive the best care for you and the care that you want in the place that you want it. There's filling the knowledge gaps of cardiovascular disease, bleeding disorder of unknown cause, and women, and all the research related to that. There's keeping Clive active and encouraging everyone to be as active as possible to lead the life that they want to lead, and looking after them from their cradle until they're hopefully dancing in an older age. And our best way, and I think the only way of doing that, is if we all work in partnership together. And I hope with a strong enough partnership that that will minimise some of the impact of the NHS being quite close to breaking point. Thank you.
Thank you very much for that. That was really interesting, and some things that I hadn't considered and might keep me awake tonight. So thank you. I'm teasing. No. It was lovely that you both offered solutions as well to the challenges and problems too. So thank you. It's very constructive. So we are moving on to our last part of the day. So we now have our panel discussion, Patient Hopes of the Future. So the panellists for this final session, if you'd like to come forward and talk about hopes for the future. We obviously have our two speakers. We have Ed, I think, joining us again. We also have Stacey McGowan, patient representative, teaching assistant and nurse at Queen's University Belfast, and Lucy Slater, who's a patient representative as well, and member of the Haemophilia Society. So we have, the title for this last bit is Patient Hopes for the Future. So we've heard about what keeps clinicians awake at night. So as patients, the three of you, what perhaps keeps you awake at night, and what would be your hope for the future to help you sleep a little bit more soundly? Anyone want to go first? I can hear you, but I don't think the microphone's working. But try again. Try again, Stacey.
Hello?
Yeah, there we go.
Hi everyone, my name is Stacey. I have a daughter who is 2 and she's got Glanzmann's. And I'm awake a lot at night. And the thing that keeps me awake at night is her future. Thinking about her going into her childhood, she wants to play a sport. Gaelic football is massive in Ireland. Anyone hasn't seen it before, it's very high contact, a lot better to watch than soccer, so get on it. So she, yeah, that's part of our culture, and I know she'll want to play that, so that keeps me awake at night. Moving into puberty, into her periods, and then moving into her sexual partners, and then moving into her life if she ever wants to have a child. So that keeps me awake an awful lot at night. And like most of the other rare bleeding disorders, we don't have treatment. We don't have a prophylaxis treatment. And I'm at the point of when I care for her during the day, if she does injure herself, my risk assessment is this going to be life-threatening? And if it's life-threatening, we go to hospital. Otherwise, I treat her at home. And that's not the way it should be. And I loved, Dr. Nikki, your presentation this morning. One of the first slides was a timeline of the treatment and how far the treatment has come from for haemophilia. And most of the rare bleeding disorders were sitting about the 1950s, 1960s. So we're way, way, way behind. And it's great that we can see how far haemophilia has come, because maybe that's what our future will look like. But we have a long, long way to go. We are way behind, and my hopes for the future is that we do get a treatment, we do get a prophylactic treatment. So whenever my daughter asks, can I play contact sport, I say yes, without any doubts in my mind.
Thank you, Stacey. I feel guilty standing here with all the treatment options. I do. So I absolutely understand where you come from. If there's any consolation, it's the same the world over. You speak to physios in New Zealand and Canada, they want to play ice hockey and rugby, and they have to counsel them against it. But some of them say simply just have to let them get on with it and realise that it's quite painful and it hurts. So, yes, thank you, Stacey.
Okay.
Anyone else?
Yeah, I suppose the things that keep me awake at night, and I've been in the more fortunate position, I suppose, of having severe haemophilia A, so treatment options have been very varied, and I've been lucky enough to have some early access to investigational drugs just by being part of clinical research for years and years. I've just thrown myself at it, because this is going to sound more altruistic than I think I am, but the thing that kind of keeps me awake at night is the next generation going through what I've had to go through when I think actually it could be avoided.
Yeah.
And that's why I've done a lot of clinical trials, because I think I've gone from injecting daily extended half-life stuff for, I think the most I ever managed to do was injecting every 4th day, but then that decreased over time, but now I'm on the BIV, whatever it's called, and that's once a week, and it's changed we've talked about this online before, Clive and I, it's changed my mindset quite dramatically from waking up in the morning and almost doing like a system check, and then what's happening today, and is it going to cause me any problems? For example, coming up to this here, if I was on previous injections and I was due one yesterday, I probably wouldn't have done it. I would have done it this morning because of the risk of getting jostled on the underground. Could mean I don't get to go to work tomorrow. I've got stuff to do, or pick my daughter up, or whatever. But on these really long drugs, that isn't a thing anymore. I don't think about my haemophilia, well, I do, but in a very different way, between Tuesday and Sunday night. And then sometimes I wake up Monday morning and think, oh God, I need to do injections today because I've forgotten. So the kinds of things that keep me awake up at night are other people not being able to experience that. And I think it's been touched on earlier on, moderate haemophiliacs don't necessarily always, or mild, don't often get access, my understanding, to prophylactic treatments because of commissioning, cost, etc., etc. But actually a more tailored thing per the individual. If they're very active and they've got mild haemophilia, would they benefit from being on prophylaxis so that they don't have these worries? That's from the wider thing that kind of occupies my thoughts as a haemophiliac, because my times as a child has passed. The damage to my joints is done. Can't reverse any of that. My career has been curtailed. Can't reverse any of that. But the future generations, and I see some of the younger haemophiliacs at the centre I go to and think, great, look at what they're doing that I couldn't do when I was a kid.
Yeah.
From my own keep me awake at night, I worry a lot about my future capability. I've got a young daughter, she's 3, and any of you that have had children are hard work, aren't they? And I'm constantly having elbow pain, just from simple things like
picking up.
Pick me up, Daddy. Oh, really? You know, I'm in my mid-40s and I'm all right now, but 10 years' time, and I worry about those things. That's my worry. I'm not so bothered about cardiovascular disease and things like that. If I have a heart attack, I have a heart attack. You know, loads of people do. But I worry about my functional ability. And that's why the things like A&E attendance or not being able to get on top of a bleed properly, or is my medicine going to be delivered on time by a nameless delivery company?
That was my day yesterday.
Yeah,
so.
Yeah. Well, you know what I'm talking about then.
Yeah.
Those are the personal things that keep me awake at night. That long term. So yeah.
Thank you.
2 aspects, I suppose.
Thank you, Ed. That's really interesting.
And a bit long-winded. Sorry.
No, not at all.
I think my main concern would be, in terms of my haemophilia centre, they not really being taken so seriously with a rare bleeding disorder rather than haemophilia. Recently, they have stopped doing face-to-face follow-ups with me, which I've now asked to go back to. But he's just not being sort of taken seriously. I have, treatment on demand if needed, or before surgery or procedures, but recently told that they would be much more concerned about me as a patient if I had factor VIII deficiency, so just sort of dismissed a bit, really. And I think I would hope that there's more awareness around women with bleeding disorders and heavy periods, really. It's something that I wasn't diagnosed, so I have factor VII deficiency. I wasn't diagnosed until I was about 28, and that was after having spinal surgery, which obviously I bled from. But previously, in the teenage years, I had been to the GP about heavy periods, and it's just a case of, well, it's kind of normal, go on the pill, that kind of thing. It doesn't seem to be the awareness of questioning about taking a good history, I would say, from personal experience of periods and what's normal. I don't think teenage girls know what's normal, really. So I would hope there'd be more awareness around that, which I think with the Talking Red is what we're trying to do. But that's obviously in our population and not general population.
Yeah. Great, thank you. Anyone else like to comment on hopes and aspirations for the future more generally, more broadly, as there's very much a look forward? Yes. It's all right.
For myself, again, talking about my son, it's what keeps me awake is having the responsibility of ensuring he's healthy and balancing making the decisions for him. So giving him the advice and particularly battling with the teen of knowing that what he's doing now is looking after his joints and things to ensure that he's still healthy in the future. So, choosing the right drugs, the wrong drugs, the sports, the yes, the no, I find that's ongoing all the time, that responsibility all the time of am I doing the right decision, because I'm thinking of his long-term impacts on him.
Yeah, and I think tying back to what Ed said is about worrying about the next generation. We hear stories, and some may have been through this, where teenagers suddenly think they're invincible. They've never had a bleed and they rebel. They don't want to take their injections. And I think back to my time, certainly when I was 9, 10. So I was on crutches. I wasn't walking for 3 weeks out of 4, and just the chance to have proper treatment to prevent those bleeds, I would have jumped at the chance. And it's great that so many people of that age have not had a bleed, not had to experience it, but I really worry that they're just going to rebel and something serious is going to happen to them, which may potentially be irreversible. And you almost want to sit them down in a room like this and have a chat with them and explain to them how fortunate they are, particularly for those who don't have treatment options still. Yes, thank you.
I just wanted to mention a couple sort of generalist things. I mentioned a few things to yourself in the break, but looking at the sort of the wider picture, gender equality, inclusion, the real basics. Is this person safe? Home safety? What support do they need? You make referrals, nothing happens. And for the female, there's the well-being of women, there's lots of things. Please ask again and again if something is not right. It all starts in the sort of PHSE education, which is just not working. If you're missing an education and you're not known to any system, this is what happens. The family will be doing the work unpaid. And, we know our young person or our family members best. If you've got a family history, please talk to your family, because one of the first questions will be, is this condition in your family? You may never know. This is where the genetics might come in as well. If you've got something really rare and you're the only person in your geographical postcode with it, it'd be really difficult. Because by the time you go through all the referral gaps and then you end up juggling multiple hospitals, it's a bit of a nightmare, and it's the family that ended up doing all the work unpaid. It's where the charities, the voluntary services come in, the PPG, the PPI, the medical research, the peer support, the lived experience needs to be included. Thank you. Anyone else got a question?
I think the gender equality piece is a big piece. I was sat in a meeting, it was the year before last, with the Pharmaceutical Company, and they asked whether women should be included in research. And we all just wanted to bang our head against the brick wall. So I think that the lack of inclusion of women in research and studies and trials, etc., is a big piece that needs to be covered. There we are. Jeff?
Yeah, actually, so I had a question picking up on some of the comments that Susie and Mary made about how do we get better treatment options to the rarer factor deficiencies and to platelet disorders. And one way is by repurposing some of the new treatments that are coming through in haemophilia. My sort of question to you then is, how do we go about doing that? What are the practical steps we need to take to begin to make that happen? And then also kind of a question to Stacey and Lucy as well, like how willing are you or you on behalf of your children to take part in trials of these repurposed treatments? Are you willing to put yourself forward to help us understand how we could use those more?
I'll start because I've got the microphone. The first thing just to say, which I hope all of us in the room acknowledge, is that the reason that we are where we are with haemophilia care is because of the incredible bravery of many of the people in this room and around the world in taking part in those clinical trials. And I think at the beginning, things like recombinant factor 8 and 9, at that time point, they were the safer option. So it was very clear to parents and families that that's what they wanted for their child. But subsequent to that, newer treatments, things like Haemophilia, some of the other rebalancing treatments coming, it is a step into the unknown, and you have all been part of that. It's no good us sitting here going, this might be a good idea. So, it's a big thank you and an acknowledgement that is you see it as early access to good treatment, which it has been, I think, for you, which is great, but it is also potentially a risk. So, going back to your question, I think the way forward with this is to look at, and in fact, it's a conversation I've had with somebody in the room 5 minutes ago, is to say, here's a rare disorder, here is a drug that we think has a possible, may work, to look as clinicians, try and get as big a group of that rare bleeding disorder together, as it were, to identify where patients are, to talk to each other as clinicians and go, could we try and set up an investigator-led study? So a lot of the things that you've been involved with, Clive's been involved with, have been studies sponsored by pharmaceutical companies. So they have organised them and set them up and done a lot of the sort of, very complex and difficult setup. And I think one of the things we have to do as a community is probably look at investigator-led things, so people like me and Susie and Nikki and Claire going, okay, we think this will work. There's a basis for it. Can we identify a group of patients, and with possibly help from industry, get a study set up to demonstrate that it does work, and then give that evidence to NICE, NHS England, MHRA.
Is that where genetics and AI might come in? You touched on AI earlier on. Now, my job background is clinical research in critical care, and we've done an awful lot of genomics-based research and repurposing of medicines using genetic data sets with good, reducing mortality by 20% type good outcome. I mean, very different area of medicine, admittedly. But would there be any mileage in that sort of approach from a ultra rare condition?
Yeah. Possibly, because I think what I'm thinking of is the things that we know are coming through the trial pipeline for haemophilia, some of which, theoretically at least, may be applicable to rare bleeding disorders. But you're absolutely right. There may be something else out there that I've got absolutely, we don't even know it exists because it's not in our field of practice. Yeah.
I think from a practical point of view, some of the difficulty with that, because my husband works in psychiatry and they're trying to repurpose a lot of drugs. If those drugs are off patent and nobody is interested in selling them now because they're cheap, trying to get somebody to fund you to do that clinical trial is very difficult. And when government funding is being cut, it makes that job quite challenging. So it's not sometimes due to lack of wanting to do these, sometimes there are obstacles that make it quite challenging. So I think we have to address all of that.
From the funding point of view, though, if something is off patent, that means it would be a lot cheaper to produce. So if it was found, I was going to say, but would that not imply a cost saving for the government?
The drug, yes, but the setup.
The setup, true.
Giant.
Yeah.
It's giant,
The cost to do the trial
is massive,
can be quite expensive. So that's why new drugs, that's one of the reasons why they're not cheap, because they need to recoup that cost. If the drug's already available cheaply, they're going to be able to do that.
Having said that, it has been possible. I mean, not relevant to bleeding disorders, but things like the tranexamic acid, the CRASH studies, which were run by the Hospital for Tropical Medicine. This is a drug that costs tuppence halfpenny.
Yeah.
And they did 10,000 people in each arm, an international study, and showed without a shadow of a doubt its safety and efficacy. We need to talk to Dr. Roberts about how he funded that. Is that charitable funding? Is it?
Yeah, I was going to say charitable.
Yeah,
charitable. Because the government said, no, we don't want to do it.
Planting a seed for thought, perhaps, but hurdles to overcome.
Gentleman there.
Yeah, hi. Very interesting talk. I work as a urologist in North London, Hertfordshire, and I would like to inquire when such patient, they come for emergency surgery or elective surgery, what's the optimum time to give them factor VIII?
So that's both very specific and quite easy to answer. Immediately before surgery.
So half an hour before surgery?
5 minutes.
Okay.
It's as soon as it's in the vein, it's working.
Okay. And do they need previously any clotting studies or anything? Do we need to do any diagnostic before, or just give them factor VIII?
So what I'd say is, with the best respect, this is something that needs to be managed by the centre that the patient is looked after by. So in the context of surgery, for example, if we were planning surgery, we would give the surgical team a treatment plan of what the patient was having, how that was going to happen, and if they needed any monitoring.
Okay, thank you.
Dr. Paul McLaughlin.
Hey, I suppose my comment is more taking on the ageing component. Of course, there's as people get older,
Why are you looking at me when you say that?
Acquire.
He's my physio. He's supposed to be nice to me. Come on.
So people, everybody who gets older acquires conditions. But of course, people with haemophilia and severe moderate haemophilia are getting older with a range of already comorbid conditions. So it becomes of what they're getting older with as opposed to what they acquire. And there's been discussions around networks and how we would maybe negotiate people to be seen locally. And I think certainly if somebody's getting older with multiple conditions that are associated with their primary diagnosis of haemophilia, I believe it is the Haemophilia Centre's responsibility certainly to have oversight over the management of that person and their comorbidities. And so things like chronic pain, multiple joint arthropathy, risk of falls, these are perhaps people who fall earlier, so they're 50 odd or 55 odd when they fall as opposed to 70. It's very difficult to get a 55-year-old into a falls clinic because they're too young, because they have a cut-off for the other things that are sort of non-standard. So I think for me it's a more globalized view of repurposing the skills and knowledge within the centre and actually maybe having additional staff that actually, because signposting can be quite hard if you're a hyper-regional centre, because of course you're then within each borough has a particular thing that only people can access. So I think it's a workforce issue and sort of future-proofing perhaps what it may look like 5 years from now, which is a medicines issue, but there's also a who may need to sort of coordinate care issue as well.
Yeah, so basically I wholeheartedly agree with that. It's just not quite straightforward for two reasons, isn't it? But I mean, in some ways that would be the ideal. But so William McEwen, who many of you will know, who is a patient rep for haemophilia, but also a care of the elderly physician, we've been working with around frailty, so kind of global health as one ages. And he did a recent talk at EHAD when he said, on this multidisciplinary team, sure, you have the doctor, the nurse, the physio, the psychologist, but also the dietitian and the audiologist and someone for the eyesight, because, wouldn't it be great to have all of this in one place? And yes, it would, except my two caveats are it will be really challenging given what the NHS is like to actually get everyone in that place. And partly, for you to do all of that as a physio will take you more time. So we need more haemophilia support, because I think that's particularly crucial within ageing and musculoskeletal health.
It's not for us to do that work, but certainly to have oversight to make sure it's happening locally.
Yeah.
Certainly had experience where people have gone locally, it didn't happen, had a really bad experience, so they then refuse to use services locally.
Yeah.
At which point you're a bit stuck because the pathway didn't work. And I think it's that that's actually mindful.
Yeah, no, that's true. So that kind of network, and I guess the only other thing I was going to say was, it comes back to a point earlier, and like, when do you go to the haemophilia centre as opposed to your general practitioner or someone else? Because like in a care of the elderly clinic, when they do this comprehensive geriatric assessment, and they're looking at the medications that someone are on, like with the best will in the world, I'm really good at haemophilia and other bleeding disorders, but you do not want me changing your antihypertensive anymore or playing around with your diuretic. I'm the wrong person. So as much as some people might want everything done at the haemophilia, I, as the haemophilia consultant, do not have that expertise. And so I think you're right, there is there's certain stuff that we need to be aware about for that communication, certain things that we can bring in-house, and then do the network and communication to others.
Great. Well, thank you, everybody. I think I'm sorry, we're going to have to stop things there. We are already 1 or 2 minutes over our schedule. Just on a personal note, I just want to say thank you to all our speakers. Thank you to everyone in the audience. Thank you for all your questions and engagement. Thank you to the Royal Society for having us this afternoon, and thank you for allowing me to play a part in this. I'm now going to hand over to Kate, our Chief Exec, to say some final words. So thank you, everybody.
Yes, and thank you, Mr. President. I hope you're enjoying that title. And yes, thank you to all of our speakers and all of our panellists. You've been amazing. And I think the biggest thing that I've realised just listening to all of you today is the power of bringing together the clinicians, the patient advocates and the patient voices, our commissioner, to be in one room together where we can explore the challenges and the opportunities. And I think in 2025, we've got the peer review will be published of all the haemophilia centres. There is the service specification coming at some point out to consultation. As has been mentioned a few times, the recommendations of the Infected Blood Inquiry, which are about the future generations, not just about the past, and how important it is. We will be publishing a major report in the late spring about the current state of access to care for women and girls. But we've got to take the opportunities of all of those reports, new service specifications and recommendations and make sure we act on them. And the only way we can do it, as Susie said, and as Mary said, is through collaboration. We've got the new Bleeding Disorders Alliance. We've got to make sure that that alliance has a voice. It brings together the nurses, the doctors, the physios, the patient organisations, but we need some more patient voices. So if anybody would like to volunteer, please come and see me. And finally, the 3 values of the Haemophilia Society are compassionate, empowering and resilient. And we try and demonstrate all of those things every day. But like the National Health Service, you know, everybody in the team are working above and beyond every single day. And one of the ways that we try and help ourselves and each other is we have a tradition called Thirsty Thursday. And it happens to fall today. So if anybody would like to join us and rehydrate, we will be in a bar across the road. But thank you to the Royal Society of Medicine. This has been a hugely valuable afternoon. It's been some great interaction. Thank you to the audience. Thank you to everybody who has asked questions and participated. And hopefully we can take the discussions forward and make a difference this year and beyond. Thank you very much.